semaine ou deux.
Et avant, t'étais...
Oh, ici et là, j'ai pas la guette. Je bouge pas mal ces derniers temps. Je vis comme ça parce que je l'ai choisi.
Dans le désert?
Ouais. Dans le désert.
Follow me, let's go out there. We won't have another chance, she said, with bravery in her eyes. But I'm not a hero, no, I'm not brave. I run away into a lion's den. Sorry, my dear, I can't go. There is too much left unsaid. But
Hello? Hello. Jeffrey? Frank? Good morning, sir. Are you ready? You want me to start? Good morning. Good morning, everyone, and thank you for being here after the wonderful dinner we had last night. And we're going to have the last symposium about how to start a congenital heart center in resource-limited settings. And I think this is a very important session, even if we don't have many attendants. But I think the minutes from this meeting are going to be very important since we have a very important people around here in this meeting. So we're going to start. With me is going to be Frank Erwin, Jeffrey Jacobs, and David Overman, and me, Nestor Sandoval. So I'm going to give the microphone to Frank to start. Frank.
Thank you, Nestor. Our first speaker is Dr. Barker. Dr. Barker is the Chief of Pediatric Cardiac Surgery at Kentucky Children's Hospital in Lexington, Kentucky. He works with Cincinnati Children's in a unique joint heart program. The joint heart program is a collaboration between Cincinnati Children's and Kentucky Children's Hospital, with the principal goal of making sure children have access to the best possible care close to home. His interests include vascular rings, tracheal surgery, pediatric pacemakers, and pediatric heart transplantation. Dr. Barker has over 35 years of experience, having performed over 6,000 congenital heart procedures, written over 30 book chapters and scientific articles, presented over 50 invited presentations and guest lectures. He's the co-author of the textbook Pediatric Cardiac Surgery with Gaspar Vrudis, and was the president of the Congenital Heart Surgeons Society from 2016 through 2018. He's the current president of the Mayo Alumni Association, director on the American Board of Thoracic Surgery, and the newly appointed editor-in-chief of the World Journal for Pediatric and Congenital Heart Surgery. Please welcome Dr. Barker, who will speak to us on the essential components of Congenital Heart Surgery Center in resource-limited settings.
Thank you very much, Frank. By the way, that was not the introduction that I sent you. I sent you 2 sentences. I didn't need to read that. I don't know where you found all that. Well, anyway, it's a pleasure for me to be here, and I want to give my thanks to the local organizing committee and to the people in the World Society that set this meeting up. It's really been very educational for me and exciting for me to be my first official meeting as, I guess I'm now the editor-in-chief, which I'm feeling like this weight on my shoulders, Christo. Anyway, and again, I'm not sure I'm the right person to give this talk, because I've always had the luxury of working in very nice children's hospitals. But I thought I would share with you a few things that I've looked up and that I've actually learned a little bit about while I've been here at this meeting. I have not ever met Dominique Vervoort, but he and I have traded emails and commentaries in the journals, and this was a very interesting manuscript from JHCVS, and a couple of things that I picked out was, the first is, I think we all know 75% of the world does not have access to cardiac surgery. The number of pediatric cardiac surgeons, according to this, is almost 4,000, with 12,000 adult cardiac surgeons, and the point of this manuscript was that if you look at this map, You can see that there are areas of the country, and Africa is certainly the one with the fewest number of pediatric cardiac surgeons. One thing that I thought while I was looking at this was that if there truly are almost 4,000 congenital heart surgeons in the country, that the World Society should have more members. And I think if we could encourage everyone who's a member here to ask one of their colleagues to join, we would double our membership. And certainly there's enough congenital heart surgeons out there that we should have more members in this society. Well, one way to improve the outcomes of congenital heart surgery is to hire somebody like Aldo Castaneda to head up your program. And this was an interesting paper that showed how the results in Guatemala improved dramatically when Aldo came. And that led to a editorial from Magdi Yacoub, who wrote this very nice manuscript in circulation, which I'm not going to go into detail, but he brought up 6 points regarding developing pediatric cardiovascular services in the developing world. And I encourage any of you to, if you're interested, to look at this. I found this very useful. But really what I wanted to focus on was a couple things. One is the research that I did when I was leading up to my presidency in the CHSS, looking at this concept of regionalization and what the best way is to develop or to deliver care. And we realized that in the United States there are multiple fragmented programs, probably almost over 150 and maybe even closer to 200 different programs offering congenital cardiac surgery. But if you look at a theoretical model of how best to deliver cardiac surgery in the United States without any preformed constraints, that 57 hospitals could actually serve the contiguous United States. And I think the lesson for this is that in developing countries that fewer regionalized centers is going to be better than fragmented multiple small centers. And this shows a map of the United States with where those would be located, clearly located at the population centers. So my research on this and some of the reporting that I've done, we've concluded that, clearly in other countries, the creation of minimum standards of care and this regionalization concept has been a mechanism to drive national improvement, and that's obviously what we would want to do even in limited access countries. Well, it's been a pleasure for me to meet Vistra, who's I think sitting over there, and of course I've known David Overman for a long time, but one of the letters to the editor that they wrote after one of my manuscripts was to point out some of the differences in different countries. And I think that's an important concept, that the way that healthcare is going to be delivered for the children with congenital heart disease is going to differ from country to country depending on what the resources and how everything is given out. So as they say here in India, most cardiac programs are in the private sector, whereas in Brazil, many programs are in the public sector, and clinicians split their time between private and public hospitals. Regionalization of congenital heart surgery can be proactively designed in low and middle income countries just now beginning to develop these services. And Dominique responded to this regarding the risk of the money flowing to centers without regard to quality. And my response to this was that governments developing new centers need to focus on fewer centers with greater volume per center to improve outcomes while simultaneously promoting efficiency, reducing health system costs, and ensuring specialized healthcare workers across all layers of care. And regionalization must also be accompanied by outcome tracking, and I think that we have the World Database with all the work Jim St. Louis and others have been doing. We need to track the outcomes and have transparency to the outcomes in order to avoid some of those mistakes that have occurred both in England and in the United States. I just want to touch a little bit my time on the American Board of Thoracic Surgery. Been very interested in what qualifies a person to be a congenital heart surgeon, and I don't want to delve into this very much, but just to point out that if you look across the globe, the requirements in different countries to be a congenital heart surgeon vary widely. You see here there's years of training varying between 1 and 5 years, number of cases 50 to 150. And just to show you what the board has decided, we have now a ACGME approved congenital cardiac surgery subspecialty certificate, which was established in 2008. And currently the board, starting in 2023, the board will require 150 major pediatric congenital cardiac procedures over a 2-year period with them. And we sort of ramp this up where they have to do 50 cases the first year and then 150 cases, a minimum of 50 cases the first year, but a total of 150 cases. And these are the index cases. Again, I'm not going to go into this in detail, but you can see that they need to perform at least 8 complex operations: arterial switch, Norwood, DKS, truncus. The other thing that I wanted to focus on was a committee that I've been involved with since March of, actually a little before that. We had our first meeting in March of 2021, but Dr. Durrani, when he was president of the CHSS, initiated a proposal, a quality initiative, where the CHSS would set forth what we feel are standards and guidelines for congenital heart surgery programs. And this is led by the CHSS, but we have 12 participating professional organizations. So you can see the list there is STS, AATS, American Heart, et cetera, and including the World Society for Pediatric and Congenital Heart Surgery. And just to summarize our current findings, and this is going to come out in great detail, and hopefully will be a simultaneous publication in multiple journals, obviously including the World Journal, that there would be two tiers of congenital cardiac surgery centers, similar to the proposal or the what actually occurs in the United States with pediatric surgery based on the American College of Surgeons, and also what has been proposed in Europe by EACTS. So the first group would be essential programs, would provide essential services for any congenital heart surgery program. The other would be comprehensive services that would optimize comprehensive, high complexity care. We spent a lot of time trying to figure out whether there should be one set of recommendations, 2 tiers, 3 tiers, and eventually, after much discussion among many very smart people, we decided that 2 tiers was the most practical and pragmatic strategy. So what we had was representation of different subgroups. So I'm not going to read them all, but surgery, anesthesia, perfusion, ICU, et cetera, and each of these subgroups put forth what they felt would be the guidelines and standards that would be important to them, and then all of the metrics for each of these groups was then reviewed by the entire committee over Zoom. And this is just a very brief snapshot of what we are recommending. Essential services would have to do a minimum of 75 cases, and again, we spent a lot of time debating that number. Comprehensive centers, and we had initially talked about somewhere between 200 and 250 cases would be our recommendation for the minimum volume for a comprehensive center. But in actuality, we simultaneously with this project, we obtained the most recent information from the STS database, and we'll be presenting an abstract at the CHSS, and it looks like the current pretty dramatic cut point for mortality is 200 cases per year, and that is slightly less than Carl Welke's study from about 10 years ago, where the cut point was at about 250 cases. So we're recommending that essential service programs have a minimum of 2 surgeons, comprehensive programs at least 3. Both units should have a dedicated pediatric cardiac OR. Essential services should have a minimum of 2 pediatric cardiac anesthesiologists, a minimum of 2 perfusionists. They don't necessarily need a dedicated ICU, but they should have a cardiac care unit within a PICU as the minimum. And then I'm not going to go through again all of these, but for example, the comprehensive centers would be ones that would, well, let me put it this way, you wouldn't do transplants or ventricular assist devices at the smaller essential services programs, but the comprehensive programs, if they can have a transplant program, they don't necessarily have to have one. Neonatal open heart surgery, we felt should be mostly performed at the comprehensive centers. And one of the things that we've tried to emphasize is that an essential program, the smaller program, should have a collaboration with a comprehensive center. And really the model that has allowed me to really see how this can work is our current model between Kentucky Children's and Cincinnati Children's, where we are essentially an essential services, and Cincinnati's a comprehensive program. And it's been, I think, very good for the children of Kentucky that we can operate on about 80% of the lesions at Kentucky Children's, but the more complex neonates, the children that need transplants or other really extensive transcatheter interventions go up to Cincinnati. So I'll wrap this up, but, and again, I'm not sure that I've helped too much with this, but I've tried to outline what we feel are the minimal essential components for an essential center in the United States. Clearly, you need all of the elements that are on this slide, and then also touch base with what the requirements for a congenital heart surgeon should be. So I'll just conclude by saying that the essential components of a congenital heart surgery program will depend on the local resources that are available. I do believe that a sort of a global philosophy of regionalization of care will optimize these outcomes regardless of the resources. Some of the guidelines that the Congenital Heart Surgery Society has set forth for essentially for North America, and the principles from the American Board of Thoracic Surgery, I think, can guide some of these principles of care for forming a new program. And then again, outcome tracking and transparency will be crucial. And again, I think the World Database is going to be a very important part of that, leading to high quality outcomes. So that concludes my talk, Mr. President, and I'm happy to take any questions. I think everyone's still asleep, perhaps.
Are there any questions for Dr. Barker?
Thanks very much. I'm wondering how can we apply this philosophy, this guidelines for the developing countries? Can we make a parallel? Can we start doing this for the different countries in low and middle income countries? Or?
Well, I think that the one of the things that will come out of this is that for the resource limited settings, that there still are minimum things that you need. I mean, you can't do cardiac surgery without a heart-lung machine, et cetera, but this will detail what we feel within each of those subgroups are important. So what's important for anesthesia, what's important for perfusion, what's important for the intensive care unit, and that will all be outlined. And I think that's something that you can take either to your government or to the whoever's paying for the services, to let them know what really is felt to be fundamentally essential components of that program. I don't know if that helps, but that's the way I think this could be applied to the low and middle income resource limited settings.
Liesl.
Yes, okay. Good morning, and thanks very much for that overview. It's not to add another one of the essential components, but I certainly think it is critical, and that is developing the heart team and the role in particular of the nurses and nurses within the step-down unit. Often it's that immediate period after ICU, which is another vulnerable period. So I think one of the things is that we often think in terms of resources, in terms of the sort of big ticket items, our surgeon, our cardiologist, our anaesthetist, intensivist. And I think as we think about new units in particular, is to train whole teams so that they can actually provide comprehensive care. So just another point from my side. Thanks.
Yeah, excellent point. And we have one of the one of the members of our team is a nurse who is quite prominent nationally in the United States, and we will have a whole section on nursing. Again, telling like they have information on nurse ratios and how many years nurses should have been working in an ICU before they're allowed to, take care of patients by themselves. A lot of details like that. Christo.
Carl, you did a very nice summary of all these issues. I think there's a major discrepancy between the motivating factors for what your group is doing in the United States and perhaps in Europe and what the rest of the world really needs. In the United States, in Europe, we're talking about reducing the number of smaller centers, centralization, and make it more efficient. With a two-tier model, I guess you're addressing some of those issues. But in many parts of the world, it's not to reduce the number of centers, it's to start centers that don't exist, to enhance centers that are really have inadequate components. So the question is, so we have to keep that in mind, but what you have done tremendously in the United States, and I've been part of that process on and off, keeping an eye of how you guys do it. The same process has to be done for the rest of the world. The criteria for a congenital heart surgery center, and once we define this criteria, that would help the local or the people that are motivating to establish these centers to go to governments and lobby and say, listen, these are the official recommendations, and hopefully eventually they can be endorsed by WHO and whatever other organizations that are relevant in order to help the pediatric heart surgeons, the cardiologists, the heart teams to lobby for the resources that they so desperately need. So there's a very different motivating factors in different parts of the world as to why these things are being done.
Yeah, I think there's different motivating factors, but I think if you were to look at what we are recommending as guidelines for an essential program, that's going to be pretty helpful to people that are starting new programs to know what they're going to need to have an effective program that has high quality results. So here.
Thank you very much for the being here and for what you have presented in terms of what's going on in the West. I have the privilege of meeting with some ministers of health from Africa visiting Saudi Arabia. And it really, what it all comes to is funding.
Yep.
All of them complain that they don't have enough money to even for basic health care. One of the countries, for instance, the minister mentioned that their budget for the whole country for the Ministry of Health was less than $300 million a year. And they kept talking about essentials. There is no way that anybody would do anything in a place where you don't have safe access to sanitation, for example, or safe water. And the other thing, of course, the problem of malaria in Africa. There are some figures mentioned that there are almost one child dies of malaria within every 90 seconds. And they keep bringing these arguments, having the balance between having these essential rights for their citizens and then the more advanced cardiac surgery and etc. It's always a very difficult balance that I don't believe that there is a good question, a good answer to it without having enough funding. So it all boils out to money and economics.
Well said, Zohair. But I mean, there's a marginal utility and a marginal return to the dollars that are spent, and depending, where you are in that socioeconomic, status and what your major health issues are, you may not be able to afford a congenital heart surgery program. So. Oh, Bistra. I can't quite hear you. If you can come closer.
Should I rate? Oh,
There we go.
There we go.
Okay. One thing to be considered for low and middle income countries is that a lot of the really active centers, which are mostly in Asia, but actually some in Latin America as well, they have much higher volumes than what we're used to in North America. And so it's very typical to see a hospital about 500 cases, and that has 2 surgeons and 1 intensivist, and they have pretty good outcomes. And so I think it's worth considering that as, to Christo's point, as we're developing something that works for this part of the world, because they have to manage with low resources. I definitely think that there's something to be learned from really well-run, good centers that we all know their names, that are doing things differently from us.
Good point. Very good point. Thank you.
Good morning. I just got up here to say, if just to make sure, if you want to hear it from the horse mouth, I'm one of those guys who is working in Ethiopia, country of 120 million people. A pediatric cardiac surgeon. Our job is not just limited to operating, and it can't be. We have a daily fight, government officials, health ministers, just to make it a point to them. Yeah, we understand malaria and pneumonia, TB, and all that kills as many more children than heart disease. But just to put it in numbers, in Ethiopia only about 30,000 kids are born every year, and about 10,000 of them needs cath or surgery, like one of those things. If a government, in many governments, what's been said is true. They always go to Western countries and look for handouts, and we don't say, don't ask for that. That's how many governments across the world work. Cooperation is essential, but there is a minimum responsibility that has to be put on a government. What we've asked is just cut down on the V8 cars that you drive every day throughout the city and give us 1 of those 2 cars every year. That's enough to operate 200 children. So we have that constant struggle to be much more than a surgeon. And it's been rightly said, it looks like it's a greater privilege to be talking about like centralizing and decentralizing centers, but our constant struggle is, instead of just being a doctor, convincing what is so easy to understand and see in developing countries.
I congratulate you for fighting the fight.
We'll have to limit
Okay.
the discussion. Carl, thank you very much for starting off the
My pleasure.
session.
Thank you.
And it's been great. Obviously, there's a lot to discuss. Many of those comments were a great segue to the second presentation by Dr. Ahmed Afifi from Aswan, Egypt, entitled Overcoming the Financial Hurdles of Providing Infrastructure, Manpower Training and Retention, and the Cost of Treatment. Ahmed.
Good morning, and thank you very much for the invitation. Congratulations on a very enjoyable and very successful meeting. I've certainly enjoyed it very much. I'd just like to share my slides. I've entered it already.
Perfect. While they're loading up the slides, one point I thought that merits at least raising, and this relates to some of the comments Zohair just said, as well as Carl. One thing that I found in my limited experience doing this type of work in Jamaica is that one argument for financially investing in pediatric cardiac care in countries that have other health problems is that when one develops heart surgery, all other parts of the hospital also get better. So all of a sudden, if you develop a cardiac surgical program in a community or in a hospital that didn't have it, the blood bank gets better, then trauma surgery gets better because there's a better blood bank, infectious disease is better, radiology is better. So when discussing investing in a cardiac program with the government, I found that sharing with them that the investment in cardiac surgery will upgrade essentially all other parts of the hospital means that they're not just investing in cardiac surgery, they're investing in healthcare across the whole hospital. They'll have better x-rays, better labs, better blood bank, and then everybody benefits. And I think that helps argue to invest resources in these programs that serve a small subset of patients.
Okay, so this is the title of my talk, Overcoming Financial Hurdles in Infrastructure, Manpower, and Cost of Treatment. I'm going to go through these using the model of the Aswan Heart Center, where I've worked for the past 12 years. Egypt is a country of around 105 million population, with a total deaths of 700,000 a year, and 40% of those are due to cardiovascular disease. We have a birth rate of 2.3 million, with 18,000 babies being born with congenital heart disease every year. The capacity of the current providers is 3,000 to a maximum of 4,000 a year. This leaves a huge deficit that grows every year. All credit goes to Professor Sir Magdi Yaqub. It was his idea and initiative. He wanted to build a humanitarian center of excellence that is available to absolutely everyone, regardless of their color, religion, or social status, to be absolutely free of charge for everyone, regardless of whether they're rich or poor, to offer the highest standards of care and service, at the same time training a generation of young physicians, nurses, and technicians, and having basic science and applied research as an integral component in the program. But the question has always been who cares, who pays, and who acts. In choosing a site, we wanted a dedicated cardiac center for a catchment area of around 3 million, a strong, transparent administration, and a supporting government, but without financial support from the government, at least initially. And this was mainly to guarantee autonomy. We chose a tiny portion of a large Aswan General Hospital, which later became a university hospital 4 years after we started. That was phase 1 in 2009. It had 28 beds, 8 of which were intensive care beds, 1 operating theater and 1 cath lab. In 2011, the capacity became 65 beds with a new purpose-built building from funds and donations collected on our side, with a dedicated pediatric and neonatal intensive care, 12 beds, and then we gave the 8 old beds to be dedicated for adults, as well as a CT, MRI, advanced echocardiography lab. In 2014, we opened the bigger portion of the center, adding 30 beds to make it a total of 95 beds with 32 intensive care beds, an auditorium, and a dedicated research lab facility. We're currently embarking on opening the new Magdi Yaqub Global Heart Center, which will add another 300 beds, and this will be in Cairo, the capital, to bring our service closer to the densely populated area. Now, who acts? Who are the stakeholders? They're the young, enthusiastic professionals, especially the doctors. They're the initiators. They're the ones who see the suffering firsthand, and they're able to come together and initiate quick wins. The people, once they feel ownership, they feel that this place is their own, they have a right to be there and to receive the highest quality of treatment, then they become partners in the program and the service provided. Strong, transparent clinical leadership, as well as administration, is a way to guarantee sustainability and to channel the funds into an endowment and a hospital insurance that will make sure that this place is sustainable, as well as developing ties with the government, again, without any finances, at least at the beginning. Now, who pays? This is a source of fund analysis for our previous fiscal year, and this is similar to the years prior, where around 30% comes from the wealthy families in Egypt and the corporate social responsibility arms of large banks and companies, while 70% come from the middle class individuals who would donate all year round somewhere between perhaps $10 and $100 equivalent every year. Of those people, the majority who come to donate are people who walk into the bank and pay in cash. They're the middle-aged or the slightly older, and the minority are the younger working class, more tech-savvy people who can donate via an online portal, website, or via text messaging. And the amount of funds varies very much every year. And during the month of Ramadan, we get around 60% of the total funds and donations for the whole year. How do we spend the money? 60% of the money goes to clinical and research activities. This includes the staff salaries, but it excludes the research grants and the in-kind donations that we receive for the clinical activities. 23% used to go towards building the endowment, but as we started in 2019, building the new center, a large portion of that is going into building the center, and 17% is for administrative fees and the marketing and advertising that is needed to raise awareness among the people. In terms of cost effectiveness, we've had many programs to optimize the theater and cath lab utilization and turnover, fast-tracking post-operative recovery with extubation in the operating room, and fast-tracking cath lab with same-day or 3-hour discharge after catheter procedures. We audit clinical outcomes, which obviously have around 40,000 patients in clinics a year, and all of the cardiology clinics have an echocardiography. We have a very active cath lab program with 25% pediatric cath lab procedures and 75% adult procedures. This also includes TAVIs and mitral clips, and there's a very active primary PCI program for the whole catchment area. They receive 4 or 5 primary PCIs every day. In terms of cardiac surgery, for the last 5 years, apart from a 2020 COVID dip, we've been doing just above 1,000 open heart surgeries every year. These are 40% adult and 60% pediatric. They also include a lot of complex valve repairs, LVADs, and so on. We've been quite interested in the modification and refinement of some of the operations, like the Jakob remodeling operation, the loose jacket technique to support the autograft in the Ross operation, and a new concept to repair the common arterial trunk, and the modification of the mustard operation that has the benefit of preserving right ventricular function on the mid and long term. Our greatest challenge actually has been the staff recruitment, training, and retention. And some of these challenges are financial and quality of life, and we're in competition with Europe and the United States, the Gulf, and even Cairo, the capital, where our staff would rather seek better pay or better quality of life elsewhere. Housing is a big problem in Aswan. It's a very, very small city and a very poor city, and commute to and from Aswan is also a big problem. Many of our staff, because all of them are very young, have a lot of governmental obligations like compulsory military service. And there are social obligations for our staff to take care of their families. This has resulted in a nurse turnover of around 16% a year, a doctor turnover of 10 to 30% a year, and a total turnover of around 19% a year. Some of our answers to that were to find the novel pools for recruitment of our staff, to grow our own staff. So in nurses, for example, we have a program of fast-tracking the essential skills and technical learning for nurses. So within 2 months, they're able to at least technically take care of the smaller babies, while receiving a long-term training and education in cardiology, physiology, anatomy, as well as investing in leadership training. We also have 2 full-time English language teachers who upgrade this part of them, and we've seen that have a good impact especially on how much scientific papers they read and how involved they are in research. We have retention programs like a loyalty program where your salary, there's an exponential increase if you're willing to stay for 5 or 7 years. And we also have a part-time employment program, which was recently introduced for members of staff who have grown and they want to fulfill their at least financial prospects, but we want to keep their expertise and our investment in them. So we keep them as part-time and we let them fulfill their financial aspirations in their free time. A nice example is the nursing staff. So to the chart on your left-hand side is the number of nurses over the years, but an interesting chart is the one on your right-hand side, where the blue line is the number of foreign nurses. Mainly they were from the UK. Starting off, we had around 80% foreign nurses who were resident, and this number gradually came down as we started to grow our own nurses. And in 2015, the foreign nurses stopped coming altogether, while we maximized the nurses coming from Egypt. But another interesting line is the gray line, where we've grown our own nurses from inside Aswan, and this is mainly in preparation for the new building in Cairo, where we want to keep the Aswan Center alive. So these would be the core that will keep the center, as many of our staff will go back to their original cities and will fulfill their requirements in the Cairo operation. This is another example of how we've maintained standards while training the surgeons. So on your left-hand side is a chart showing the numbers of arterial switch operations for the individual surgeons. So this is surgeon 1 and surgeon 2, and then 3, 4, and 5, and so on. And you can see of the pattern of intense training at the beginning. There's a plateau and with a simultaneous handover to the next in line who goes through the same curve. But on your right-hand side, you can see that in spite of surgeons starting at different phases of the center and the different case volumes, we've maintained a mortality rate for the arterial switch operation of at or below 9%. These are the numbers of the arterial switch operations. Our best year was our worst year was 2012, where we had a mortality rate of around 37%. But then our best year was 2018, where the mortality rate was 3.5%. And as we loosened the criteria for admission, for many of these babies who come very sick, sometimes ventilated for other hospitals, and sometimes not very up to standard hospitals. So we've lost many of them, especially due to neonatal sepsis. Now, the recruitment pools are our way to identify potential. A lot of our doctors and nurses and technicians, you can't tell from an interview or a CV whether or not they have the potential. So we need a way that we can look at, sort of observe how they handle themselves and whether or not they're good potential. And we've targeted that through an observership program, a fellowship program, and also interactions through meetings and workshops that we do in Aswan. These are the numbers of observers that come in. Most of them are from Egypt, but many of them are from other parts of the world. And it's not only limited to doctors, but there are others like in the labs and biomedical engineering and so on. We have an active science and practice workshop series. We do around 20 workshops a year, and the ones of surgical significance are the management of TGA and mitral valve repair, with an emphasis on rheumatic valve repair and surgery for the aortic root. These consists of wet labs and animal models, 3D printed models. There's live transmissions from the ORs and cath labs, didactic lectures, and hands-on simulations on CT, MRI, transesophageal echo, and so on. These are the numbers of our international publications coming out from Aswan Heart Center per year. We also have a journal that is PubMed indexed, so I would encourage you to perhaps submit something there. It's also open access, and it has many papers from a lot of international key opinion leaders in the field of surgery and cardiology. So to conclude, in low and middle income countries like mine, there's a huge demand for cardiac centers, and there are even bigger challenges. But financial support from our point of view comes from the people. If you are able to get to them, and if they feel that they own the project. Investing in the young is extremely important, but without dilution of training. And we should come up with ways that fit our circumstances to identify, train, and retain human resources. And thank you very much for your attention.
Crystal.
Congratulations, Ahmed. It's amazing what you guys have achieved with Sir Magdi Yaqub in Aswan. You talked about the attrition rate of losing personnel to other centers, maybe perhaps to Cairo or even to other countries. So that's a big problem because these are highly trained individuals that are then lost to their local or to their native country. Now, on the other hand, there are trainees in the West, United States, North America, Europe. They finish their training, their congenital fellowship, but then they can't get a job immediately. So I'm just wondering, while you have an attrition rate in that direction, whether positions could be offered to freshly trained congenital surgeons in the search of a job, perhaps to spend 1 or 2 or 3 years in a center like yours or other centers, and in a way get their learning curve through, but then provide also a service. One of our trainees, Hamoud Al-Kindi, spent, I think, a year and a half at your center. He was planning to do his fellowship in Edmonton, but then ended up going to Aswan. And now I believe he's very successful in Muscat, Oman. So anyways, I'd just like to get your thoughts and others of this possibility in a structured way to move personnel in the other direction, even if it's on a temporary basis.
Well, thank you, Christo. This is a great question. Obviously, the challenges of losing our staff, these are our biggest investment, has always been a big challenge. Now, first of all, all the slides that I've mentioned, they're the success story. The point was not to brag or to blow our own horn, but just to give hope to the rest of the low and middle income countries that it is actually possible to achieve at least some form of success in this domain. But I've also undertoned very much the difficulties of living and working in Aswan. We do get a lot of applications from people abroad who want to come and spend the time. I think a very few actually materialize. But we welcome anyone who wants to come and help, and for us this is a great opportunity. And I think with opening the new center in Cairo, a lot of the challenges of living in Aswan will no longer be there. And because it's 3 or 4 times bigger, then we will be able to accommodate so many more.
So this is a great discussion. We're going to take 2 more questions here, but then after these 2 questions, what we're going to need to do is make a panel discussion at the end, because otherwise people are going to miss their planes or miss the end of the session. So in order to make it so that everybody can hear all of the talks, we'll take these 2 questions and then we'll try to hold the remaining questions until the panel discussion at the end.
Thank you very much. My name is Jamil Ismail from Nigeria. I think what you have achieved is quite inspiring in terms of the community engagement and the local philanthropy. But we have some challenges. Most of our programs are entirely public service or public oriented in the public hospitals. And we have this challenge of lack of trust and confidence by the local philanthropists and the community in supporting government activities because they believe the government has the resources. It's just lack of prioritization. Like in Nigeria, it is estimated that with 10 million USD, you can have a modest center, including equipment, infrastructure, and the training. But Nigerians spend about $1 billion every year in medical tourism outside the country. And when the COVID came, because of the interest and the politics behind it, in one sweep, about 500 million USD was released as part of support for healthcare, to give credit to some private institutions. So people believe that there is money. So I'm thinking maybe the strategy we can also use in some of the countries is to really engage in the real lobby, because I think we have to change the language we are speaking to the politicians. That language of using maybe the mortality, the morbidity, I don't think is sinking into them. We have to really think of a better language in terms of looking at the economic implication of all the cost-benefit analysis and then talking to them like that. And if the government can invest some money, then we can win the philanthropy so that they can support the system. But we have that challenge. So I don't know what if you can shed some light on.
No, I agree with you 100%. This is an overwhelming challenge. In Egypt, we've had that perhaps a decade or two ago when there was virtually no proper pediatric cardiac surgery. And even 2 decades before that, there was no adult cardiac surgery, apart from very individual stuff. Of course, I can't compare because we're blessed with someone with amazing credibility, Professor Yaku, but what I can tell you from our experience is that Egypt also relies on the government initiatives for, especially for pediatric cardiac surgery. There are very, very few centers, ours included, who do not do that. But what we found is that it's so much easier to speak to the people because they identify more with a dream that you have, with a hope that you have. But the politicians, I mean, they want your papers and your forms and everything, and still it doesn't really materialize. So I don't know if it's possible in Nigeria or not, but perhaps lesser reliance on the government and perhaps more on the people around. And actually, a very good example of that is the center in Tenwik, Kenya. It's a small center. It has not relied on the government, but from the goodwill of so many people around. And it's such a small town, but yet they've achieved a fair amount of success.
Thank you very much. I think this has been a great discussion, especially the questions from Christo and our colleague from Nigeria as well. What we're going to do now, because we have 8 more presentations to get through before we proceed to the African Society's constitutional signing, I think what we need to do is we'll go through these 8 presentations and then hold the questions rather than after each presentation for a panel discussion at the end. A lot of these presentations are closely related and the discussion will flow through quite well together. So thank you for your excellent presentation about the program in Egypt. And now we're going to move to a discussion about the program in South Africa from Darshan Reddy. So I welcome Darshan Reddy to the platform, to the podium.
And we just encourage the speakers to limit their talks to 15 minutes as stipulated. Thank you.
Thank you very much, and good morning to everybody. I'll try to get through this as quickly as possible in the interest of having a good, robust discussion at the end. Apologize for the long title that you see on your program. I think I might have been sleepy when I sent the abstract. I didn't mean to send the whole story through like that. This is actually the title. And I'm going to give you a little bit of a different perspective. This is the perspective of a surgeon who's worked in a university government hospital for my entire career as a cardiac surgeon, and who eventually got frustrated with the issues that we're talking about today in terms of trying to convince politicians that this is an important part of what they should invest in, and decided that maybe we should start talking to corporates and we'll get more achieved. This is South Africa. This is a map of the country. We're a population of just under 60 million people, of which about 18 to 20% of people have health insurance. So the talk I'm talking about today is private-public integration, and I'm talking about those basically 1 in 5 people who are insured. This was the referral patterns in South Africa before 2017, when we started our unit. As you can see, the unit in Cape Town treated most of the patients on the western part of the country, including Namibia, and the unit in Johannesburg, which Rob Kinsley started, and many of you have visited the Walter Sisulu unit, was in Johannesburg, treating all the patients from KwaZulu-Natal, which is on the east coast, including babies from Botswana. How this has changed in 2022, this is the current landscape, and we now in Durban look after all the patients on the eastern seaboard of the country, including Botswana, and we have patients referred from Mozambique and Zimbabwe as well. So we now have 3 centers in South Africa taking care of this geographic region. And people say to me, well, why did you decide to start? It started with a patient. We had a baby in Durban who was in a private facility, who needed a structurally normal heart, who had complete congenital heart block. And this baby never made it to Johannesburg, and I thought it's an absolute tragedy that a child with a normal heart could die in a city the size of Durban without any facility. So the first thing I'll mention is finding the right place. I think it's extremely difficult to start a pediatric cardiac program in a hospital that does not do cardiac surgery. So we found this hospital, Len-Medikweni Hospital, it's in Durban, great hospital, had a very good reputation for adult cardiac surgery as well as cardiac transplantation, and the hospital that the first successful heart-lung transplant on the African continent was done. So I didn't have much convincing that this was the right place for us to be. There is a certain level of acuity that comes with working in a hospital that already does open heart surgery, and I find that it's pretty, in our experience, it was actually quite easy assimilating into this practice as opposed to a hospital where they've never seen a heart-lung machine. And as Dr. Jacobs said, I strongly believe that a rising tide lifts all boats. So if you actually improve the quality of the service that you're delivering, everything else in the hospital gets better. The second point I want to make is finding the right people. It's really difficult to do this on your own. I share the sentiments of my colleague from Aswan in Egypt. Having somebody of the stature with you really makes a huge difference. So this is Rob with myself. And Rob Kinsley's been involved in the start of our unit. Even when he didn't live in Durban, he would fly up for some of the early surgeries that we did. And I have a great team of people who I work with, including pediatric cardiology, fetal imaging, and hospital management. And that's just a picture with our first baby. Just to tell you a little bit about this, Rob and I spoke for a long time about starting this unit in Durban, and we had this great plan. Okay, we're going to start off small, we're going to do the low-risk cases and work our way down to babies. So we started on the 1st of March 2017, and on the 17th of March 2017, we get a call from pediatric cardiologists to say, I've got a baby, a neonate with transposition. What do you guys want to do? And unfortunately, we did the case, baby did very well, and that kind of launched us. And that's why I feel when I speak to colleagues in Africa, that when we're talking about, what your center's capable of, I certainly feel that if you can do a neonatal switch in a hospital, there's a certain level of expertise, not just from surgery, but from anesthesia, from ICU, that's required to get a survivor. And it gives me an idea of where a center is. In terms of new referrals, these are old slides. So the referrals have gone up quite a bit. During 2020, I think everybody experienced a bit of a lull. In terms of surgeries, we started off doing very little, and people said to me, what are you doing? Aren't you anxious that you're not doing much? And where are the patients going? And I think the best advice I got from one surgeon was that if there's nothing to do, do nothing. Go to the beach. And that's been fantastic. I wish I could do that now. in 2021, last year we did 140 cases. Bearing in mind, I'm the only surgeon there. I still operate at the university hospital, doing about 60 cases a year. In terms of cath lab, the numbers have gone up as well. In terms of the training program, when I can get Rob off the golf course, it's fantastic to have somebody of his expertise in the ICU training up our nurses. We just go through physiology, the patients that are in the unit. We run through the usual basic ICU nursing stuff, and I have to say our staff retention has been very good because of these initiatives. You can't be an island, and South Africa is far away from the rest of the world. So unless I have to literally take a week off work with no operating and come to meetings like this to learn about the techniques that we've been discussing over the few days, it's not possible to actually function. We have a national academic program. I host meetings in Durban, and you'll see Susan Foslu and some of our other colleagues from around the country who join us at these meetings. I'm sure many of you that have been to Rob's meetings in Johannesburg will understand the flavor of these meetings. There's obviously a lot of socializing that also takes place. And then in terms of the international side of things, I've still maintained my links with Michigan. We had Rick Oye in South Africa in 2017. And then in 2018, I realized that we had a bit of an Achilles heel in the ICU, and I got John Chapi out to South Africa, to Durban, to give us an entire day of lectures, including training of nurses and the rest of it. And it's really important because this so-called twinning or partnerships with international hospitals is really key, including with people in this room. I'm not going to talk more about the World Database other than to say that we subscribe to it. I have to confess that on my list of things to do in a week, this is very near the bottom. And as I've said, as Jim St. Louis said, it's not possible to do this as a surgeon. You really need help. And this is the phase that we're at now in terms of getting other people to help us to be able to run this database. So with the transplant program, similar to our experience with congenitals, we decided, okay, we'll start with some, fairly straightforward transplants, nothing crazy. And this patient of Rob's pitches up, who's had multiple surgeries for pulmonary atresia and needs a heart-lung transplant. And again, the patient had his surgery, went very well, and it kind of launches our transplant program. With regard to the private-public partnership aspect of it, we created the Children's Cardiac Foundation of Africa in 2018. And the reason for this was that we felt that we had built a center which was working very well, but it's only accessible to 20% of the population. And we had capacity to be able to offer this to children within the state sector. So we approached government and we said to them, we're happy to help with some of your capacity. We can take some kids off your waiting list, of which there are about 500 kids in my region who are on the government hospital waiting list. And the politicians thought about it and they said, yeah, maybe, well, we'll think about it. So we approached corporates and we said to them, if you give us this much money, we can operate on 4 kids every month and we can help reduce the waiting list. And this is what's happened. Every month at the moment, we take 4 kids off the waiting list at the state hospital. The entire diagnostic workup is done at the university hospital. They simply come across to us for surgery, a few days of ICU, and then they transferred back. In the next week, I have 3 of these kids coming across, and it's worked very well. So the lessons we've learned, this is a very sort of informal, anecdotal part of the talk. Identify a hospital group that shares your vision, and engage with the key role players. And this is something I learned early on, is talk to the people that make the decisions. Our hospital board is very approachable. Our chairman is very approachable. So I went to him and I was very clear about what I wanted to do. The second bit of advice I got from one of our transplant surgeons was that ask for more than you need. If you need a bypass machine, ask for 2, because they only buy you half of what you need anyway. They were very upset with me that I'd asked for an ECMO machine and I hadn't used it for a year. And I thought that was very good because we had really good outcomes. We didn't need any patients on ECMO, but they were upset that they spent all this money on an ECMO machine that was just lying there. you got to speak their language, and this is something that we're not trained to do as surgeons. We can come up here and talk about, you know, all of the technical aspects of surgery, but when it comes to reimbursement models, you know, this was a language that I needed to learn and understand, because this is what they understand. And you have to understand their culture. Their culture is that I'm investing a lot into you, and what happens if you decide to leave and you decide to go and work somewhere else? Because the situation in South Africa is very different to other parts of the developed world, where if a surgeon decides to leave a program, they can replace him, you know, within a week. In South Africa, it's very difficult. The hospital's putting out a lot of money to invest in a program that's basically built around one surgeon, one cardiologist, and a few other people. So you have to understand that corporate culture. In terms of the team, I think communication is key. I have a small team that I work with. We talk every day. You know, my routine since I've been in Marrakesh, I call my wife, then I call the cardiologist. That's just how we are. You got to have a team that's willing to go the extra mile with you. The first neonatal switch that we did, I stayed in the hospital. The first NOVA that we did, I stayed in the hospital. This is just what you have to do. You're not in a first world unit where you have a great intensivist that you hand the patient to and you go home. The first hypoplastic left heart, our pediatric cardiologist got onto a helicopter to fetch the baby. You know, this is what you have to do if you want the outcomes that are acceptable. And the last point I want to make is that organic growth is ideal. You can't force growth. You can't hire people to grow your program. Your program has to grow, and you basically grow with it. And this is the lesson that we learned. I'm sure many of you have seen this, and it's, you know, it's related to high performance teams. And every time we've had a new person join the team, you have this period of finding your feet. Okay, how does it work? We had this when Rob joined us in 2018, because we'd been already going for a year. And then, you know, Rob comes into the mix, and it's sort of, okay, well, you know, how does everybody work around it? And then once you go through the phase of the storming, and you get to like norming, and then eventually everything gels, people work. And this is an important point too. If you don't create the culture will create itself. Don't be a jerk in the operating room. If people like you, a lot of this is a lot easier. If people don't like you, it becomes very difficult. From our point of view, people come, they work with us. If they like it, they stay. It's fantastic. If they're a bad fit, they pretty much just leave, because it just doesn't work for them. It doesn't work for us. So these are just some of the softer points that I think haven't been highlighted in any of the previous presentations. Just to mention that at the end of it all, we do this about patients. And our patients now, like I said, come from various countries. They have entirely the same experience. So whether we operate on a kid from the government hospital waiting list, a kid from Botswana, or a child from KwaZulu-Natal who's got health insurance, they get the exact same operation, they get the same consumables used, they get the same patient experience. If you come to our ICU, you see them next to each other, it's very difficult to tell which kid is from where. And I think that was what we had hoped to achieve, and it seems to be working very well for us. I'm happy to take any questions during the discussion about any of these aspects. Thank you.
So, thank you very much, Darshan. Truly impressive work, and I look forward to discussing it further with everybody during our panel discussion. The next speaker is our awesome local host, Drissi, who will be discussing collaboration for training between indigenous teams. Again, Drissi obviously has organized just a massively awesome last several days that we've all enjoyed and learned a lot, and we're looking forward to hearing him talk this morning.
Thank you, Jeff. It's my turn to talk about the collaboration for training between indigenous team in cardiac surgery in general. Training a specialized congenital and pediatric cardiac surgeon is a complex process, and it is challenging even in high-income countries. In low and middle-income countries, this training will become more challenging because there is an issue about which program we should follow. It should be done according to the high-income countries' programs, or this program should be adjusted to the reality and the epidemiological data, or we should maybe have a program or both of them. According to the Cape Town Declaration on access to cardiac surgery in developing countries, the aim to advocate for training of cardiac surgeon and other key specialized categories at identified and endorsed centers in low to middle income countries. But in reality, the implementation of this declaration on the ground was more challenging than expected. The paper which was published by the World Society of Pediatric and Congenital Heart Surgery about the current status of training and certification for congenital heart surgery around the world pointed that there is currently lack of consensus and standardized criteria for training in congenital heart surgery, with a significant disparity between continents and countries. So this paper pointed the challenges in training and certification for congenital heart surgery. The competence is difficult to evaluate, and the successful work of a pediatric cardiac surgeon depends on competent multidisciplinary team. So we should think about we should determine how to successfully train such a multidisciplinary team and ensure their competence. In Africa, as you know, is a huge country, and there is 54 countries, and the congenital heart surgery has not been a priority, as was pointed this morning, and the focus is on communicable disease. So the result is there is few established programs in pediatric congenital surgery in Africa, and opportunities for African surgeons to train abroad is even more difficult. And when trained, inadequate resource and lack of well-trained staff in pediatric ICU, anesthesia, perfusion, nursing may influence the results. And the case profile are different between high-income and low-income countries. So this surgeon, when well-trained, perform below the level for which they were trained. In the same paper, there is three categories of training. In Egypt, for example, is volume case training for pediatric cardiac surgery. In Morocco, there is no, according to our program of education, there is no citation about congenital heart surgery training. And in South Africa, you need at least 2 years in a recognized center. So what is the problematic of training in Africa? First thing, there is a shortage in cardiac surgeon. And the shortage is because there is shortage in training opportunities, and sometimes a lack of motivation. Young surgeons, when they start their program, sometimes they leave the program because there is no clear visibility on the future. The other situation, highly trained surgeon, but non-functional on the ground because lack of equipment, lack of confidence and expertise, and lack of specialists in other essential fields to sustain a cardiac surgery program. So collaboration between indigenous team, according to our analysis, will offer solution for both problems. For shortage in cardiac surgeons, opportunities for training in a similar or close condition to the countries of origin will help to this younger surgeon to adhere to the program. And there is more visibility because a young surgeon when trained, for example, in Africa, it will give him more hope. And if it is feasible in another developing countries, it will be feasible in mine. When a high trained surgeon come back to his country, he will need an accompaniment to establish a sustainable program, and there will be opportunities. The collaboration between African countries will give more opportunities for training to better to other necessary specialties. So, what are advantages of collaboration between indigenous team? There is the same case profile. It is less intimidating to start off in a similar environment to yours. And the cultural aspect is another important thing, because when the young surgeon move from, for example, from Bamako to Marrakesh, culturally is not a big gap. And easier access, more work to be needed in this area to make it easy for movement between African countries. The cost of living is another issue to promote this. Is another advantage of this exchange. In this paper, we compared the cost of living in Marrakesh and Marseille, which is a French city in the south, and we found that the cost of living in this city is much higher than in Marrakesh. And we asked our residents in Marrakesh what is the cost of living during the residency, and between 200 and 350 of expenditure per month they manage to stay for the whole residency program. Moroccan approach to indigenous collaboration team is done through the Moroccan Agency for International Cooperation. 3 ways for foreign students to access to the medical schools in Morocco. First way is as a fresh high school graduate, he can access to the Moroccan medical school and start his study. Second option, to access to the specialty training through a residency exam, like Moroccan colleagues, or direct access to specialty training without residency program after requiring the department chief agreement. Meaning the resident can start his program just if he found a position, free position in a university hospital without taking the residency program, which is a big advantage for many African countries. In all cases, there is a scholarship offered by the Moroccan Agency of International Cooperation. Our department, through his experience, developed an approach to indigenous collaboration. For the training, concerning the training of the surgeon, we train a new surgeon through our residency program, and we have few of them now. We did accompaniment of trained cardiac surgeon through providing a support to trained cardiac surgeon to start their cardiac surgery program in their countries, and to support NGO program as well as our hospital adhere to many NGO programs in the region. So for the training of cardiac surgeon, the residency program in Morocco is 6 years of residency. In general, 5 years in Morocco and 1 year abroad, and in general in French, because the majority are French-speaking countries. And they have rotation in adult and pediatric cardiac surgery with rotation in ICU and in cardiology. And the aim is to train cardiac surgeon and accompanying them to start their program. So our experience or the current situation, we've trained one cardiac surgeon from Benin, and he is working to start his program. He's still staying in France for the last 3 years, but he told me recently that he will come back home to start his program. And now there is 8 residents from 6 different countries, from Mali, Gabon, Niger, Burkina Faso, Burundi, and Mauritania. And all of them, in Mali, for example, there is already established program. Niger as well, they are starting. Burundi not yet. Burkina Faso, they will start. I think they already buy the equipment. The accompanying trained cardiac surgeon through humanitarian missions. We've done 6 surgical missions to 4 different countries. And we offered fellowship for trained surgeon, and we have one from Nigeria now. We receive another one, and we offer short visit for exposure for colleagues from who are trained and not working enough. And through a memorandum of understanding of cooperation with many other hospitals, our university hospital can organize missions. So, and there is 2 success stories. We were involved in Mauritania program, and now we are happy that this program is working. And we were involved in Sokoto, Nigeria, and I'm happy to hear that there is a local initiative that they start working together, and the program is going on slowly. There's some pictures from what we have done in our missions. So our department approach in terms of supporting NGO programs, we have cooperation with physician cross-continent, and we trained for 2 years 16 professional physician and nurses from Kinshasa for 2 years, and it was funded by Physician Cross-Continent. We adhere to Nabadat Foundation in terms of missions, and recently La Chaîne d'Espoir did some contact with our hospital for some collaboration, and we are willing and happy to adhere to any cooperation with the World Society of Pediatric Congenital Surgery and African Society of Pediatric Congenital Surgery, and eventually with the World University of Pediatric Congenital Surgery, if there is any initiative to choose centers in Africa to become as centers of training for colleagues from Africa. So in the end, and in conclusion, we need to involve politician leaders, and the African Society of Pediatric Congenital Surgery should make our voice heard in African Union. And we need to adhere to the World Society database and through the African Society database in order to accurate evaluation of the current situation and to take a practical action to improve our practice. Thank you.
Thank you, Idrissi, very much for that wonderful approach to collaboration and kind of recommendations, and I'm sure at the end we're all going to have a lot of discussion. Now it's time to move on Jim St. Louis. He's going to give a lecture about the importance of following surgical outcomes with the validated databases. And this is very important because it's a validated database. It's not just database. Jim is the leader in this database, so thank you, Jim.
Again, I've had this ongoing trend of talking about data and databases, and it's humbling to sit up here and talk about validated databases and data when we clearly have so many additional issues to deal with both within the continent and outside the continent. But it comes back to the basic tenet that starting from a great foundation and starting from an area where we can acquire the data to do the things we need to do is important. So I'd like just to spend a brief period of time talking about the importance of validated data and, you know, looking at some historical issues that when we didn't have this data and move forward from there. So again, the mission of the African Society is to provide access to appropriate care, medical and surgical care, and it is to provide excellence and emphasis on education, research, and community service. And I hope I've shown over the last couple of days that the importance of the ability to acquire data to achieve these missions is paramount. So again, you know, the idea of acquiring data to perform outcomes analysis, there are several important reasons. We want to do no harm with our patients. We want to provide the most effective and efficient medical care possible. And we've heard a couple different scenarios of how to acquire that, whether through it's the governmental sectors, private sectors, or from the population itself. So there's some interesting ideas of where to go to acquire this support to ability to import data into a central system. And again, as we've heard over and over again, we want to continue to evolve our surgical techniques and skill sets, and we can only do that through having collaboration of sharing this experiences both one-on-one and via the evaluation of data sets. We want to create a community for exchange of knowledge and experience, and we want to really be able to efficiently use our limited resources. And again, of course, repeat our successes as we've seen today and learn from our errors. So I think that a lot of this stems from badness or, you know, issues that we've had over the decades, and I draw them back to the Bristol scandal and the issues that occurred during that period of time in the 90s when parents rose up against a single institution, what they perceived as substandard outcomes for the care of their children. And it exploded into what I think some of the reasons why we believe now data is so important. And, you know, the Bristol experience, in which, you know, 35 patients, babies died and dozens were left damaged, gave us some good insight into, you know, why it's so important to acquire the information that we've talked so much about during the last few days. And the Bristol report which was delivered by Sir Kennedy, really highlighted the poor organization, failure of communication, lack of leadership, and a club culture with failure to put patients at the center of care. And I think as we go through and develop these programs and continue to evolve programs, understanding, you know, the history and the mistakes that were made is paramount. And I think what I'd like to take from this is that inadequate data collection, inadequate monitoring of data was one of the foundations of why this occurred. And this wasn't in Britain. We saw this in Canada, and we saw it in the United States, where parent groups would rise up and really question, you know, how centers were working. And the centers that had poor outcomes were those centers that weren't able to provide the data to justify what was going on. So data is important. You know, a common language of nomenclature, as we've heard, is critical. Use of a uniform core data set, mechanism for data collection, mechanisms for evaluating the case complexity. You know, a center does all ASDs and VSDs are going to have different outcomes than centers that do transpositions and Norwoods, and we have to be able to evaluate that. And then we need a really good mechanism of data verification. We'll speak a little bit about these standards to follow lifelong progression of our patients, because it's more than just getting them out of the hospital, it's following them throughout their life. We've heard the nomenclature topics during this meeting, and I was privileged to be involved in the International Society for Nomenclature, and it's pretty well standardized through the assistance of this organization that we now have a standard set of definitions for procedures as well as congenital heart defects. So the mission statement again of the World Database, and you've heard me say this over and over again, is really further knowledge concerning the global practice and outcomes of pediatric congenital heart surgery. We want to foster an environment of quality improvement, and we promote scientific investigation. And we do this through acquiring the data. So again, a set of standard variables shared and harmonized across the globe is important as we move forward in Africa and attempt to, in parallel to the development programs, training systems develop the ability to acquire the information we need. And we do this in the World Database, obviously, through an online mechanism in which centers submit their information and detailed information on certain procedures and less detailed information on others. I like to just talk about a very successful database. If we're talking about validated databases, it's not Society of Thoracic Surgeons Congenital Heart Surgery Database. It began accepting patients in 1994. Recruit was slow in the beginning. Getting momentum took some time. But at this point, over 120 centers across the United States participate in the Society of Thoracic Surgeons database with a 95% penetrance to all the cases done. It involves almost 400 surgeons around the country. And its function in the foundation of all databases is to provide quality improvement tool for individual centers. And it's a mechanism for risk adjustments, as I said, which is incredibly important. And if you look at the growth of the database, there are well over 500,000 patients that have been now submitted to the SDS database. And through the efforts of individuals like Jeff Jacobs and Marshall Jacobs, they really work hard to come up with that important risk stratification system so we know what to expect in our operations and how we can compare our outcomes. And this will be different for every country, there's no question. The variables that put into this sort of risk adjustment model will be different than the variables needed for South Africa or India or any other country. And then a very nice paper published by Jeff looking at, the trends of pediatric heart surgery. That's important to understand the data, is to understand how you're doing. He looked at over 200,000 patients, indexed operations from 118 centers, and the overall discharge mortality was 3.4% during the initial phase of the database, and the follow-up over the next decade had dropped to 3.1%. And this is the importance of acquiring validated data, is to watch our trends. So clearly improvement of mortality over the period of time during the database is so nice. And that information was used to assist centers in their ability to participate, to operate on children. And then and the message from this paper was that the data important trends and outcomes can be acquired and investigated for both institutional, national, and global outcomes. We really can describe specific patient characteristics, and that was an important part of the evolution databases. The specific individuals have different anatomy than others, and we're trying in the database to be able to capture that, and that's very important. And again, of course, the importance of risk adjustment and assessment beyond 30 days. And it's difficult. And Dr. Jonas and I have talked about this a couple of times, and we're trying to do a few studies to really follow up, not just the 30-day, obviously, because everything is evolving, that 30-day outcomes are improving, even in centers in this continent, but to really evaluate centers, patients beyond the 1 year, 2 year, 5 year, and 10 year. And again, the importance of validated data is crucially important, and we can't overemphasize that. The information we get out of any data set is only as important information put in. And there's a very rigorous evaluation process that Dr. Overman leads the United States, in which we assess the completeness and accuracy of data put into databases within the United States. And these are audits that we've talked about a bit in the United States, but very encouragingly, the STS database is really able to generate information that's very authentic. And if you look at these completeness and agreement with general data and mortality, it's pretty phenomenal. The information put in is very accurate, and we wish to strive for that, the same with the database within Africa. So again, the advantages of forming a national database or intercontinental database, as we look at, is to collect and store information within the continent. We want to get national support. We want to get our governments within the continent to support this and see it as important as providing the heart-lung machine or providing the nurses. It's important to understand how we're doing and be able to judge ourselves honestly. We want to also get public support. As we said, there are a few different scenarios of how gathering resources, and having the data to go to the public and say, this is what we do and this is what we need to do is of importance. And we want to bring members of our society together, like we've talked about over and over again. I think this is the first step, we've taken in the last 3 days to bringing this society together. And we want to be able to control the distribution and as I said, assure the validity of the data that we put in. And of course, research and publications, as we've seen by some of the great science that's been presented today. So again, why is the data important? Well, it's simple. It's what we do. It comes down to data is cold, but the results of the data we collect is important for our patients and our success with these patients. So again, thank you very much. It's been a great meeting, and I've been very, very honored to be a part of it all.
Thank you. Thank you very much, Jim, for your wonderful lecture. We'll next take Dr. Jacobs, who's also going to talk about his experience from his pediatric cardiac surgery program in Jamaica. Dr. Jacobs.
Thank you very much. Again, Jim, great talk. The work you're doing with the World Database is just so important. What I'm going to do in 15 minutes is try to share a little bit about what I learned during the time that I spent over the last 15 years in Jamaica. And this is one of hundreds of surgical missions that occur across the world. And there's nothing special about this one that differentiates it from any of the other missions. But I thought that with this discussion, there's valuable lessons I learned while I was down there that I think merit sharing to facilitate some of our discussion. So to get started, a little bit about Jamaica. Jamaica is in the Caribbean islands, which is close to North America, kind of near Central America. The Caribbean plate has more than 7,000 islands, reefs, cays. Jamaica lies in the region of the Caribbean that's also called the West Indies. It was named the West Indies because Christopher Columbus landed there in 1492, believing he was in India. And the Caribbean had 37.5 million people by the year 2000. This is a map of Jamaica and the Caribbean and a variety of islands around Jamaica. So there is Jamaica. Right next to Jamaica is Cuba. There's Haiti and the Dominican Republic. There's Bimini, where some of the best fishing in the world exists. I love going to Bimini. This is the 5 most populated islands in the Caribbean. So Jamaica is the 5th most populated island after Cuba, Dominican Republic, Haiti, and Puerto Rico. And it's an island nation, 146 miles or 234 kilometers one way and 80 kilometers the other way. It in the past was called Santiago when it was a quotation mark Spanish possession, and then it later became the British West Indies Crown Colony of Jamaica. Here's a map of Jamaica itself. That's where people from the United States go to sit on the beach and drink pina coladas. It's Montego Bay. On the other side of Jamaica is Kingston. That's their capital city. There's not many people going on vacation there, but that's their huge population center. What I'm going to share is information from a series of 12 trips our team made down to Jamaica, where ultimately we operated on 121 patients with increasing numbers of cases each year. And by the end, the overwhelming majority of the cases were done by a Jamaican surgeon, my good friend Sherrard Little, who now is running a successful independent program down in Jamaica. The first time we went down there was in 2006. We went down as a fact-finding mission. We didn't operate at all. We just were trying to learn the lay of the land. Our cardiologist was Jim Huda. Dave Cooper, a very young Dave Cooper, was an intensivist looking in the ICU. Tom Chansey's there, who's a perfusionist, and we brought 3 nurses with us as well. And this was to figure out if we could operate there, what we needed to do, and how to organize it. We visited a hospital called Bustamante Hospital for Children. This is a hospital that's the only children's hospital in Jamaica and one of the few in the Caribbean. It was built in an old British Army barracks. So this is the front entrance to Bustamante right here, and that's the front entrance sign. It's in a fairly dangerous neighborhood. All of the lots around that area are surrounded with electrical barbed wire fences. It's quite a rough neighborhood. This is the actual inside of the hospital right by the front door. This is the family waiting area. If you show up there at 6 in the morning, that's what it looks like. If you show up there at 6 at night, that's what it looks like as well. It's always filled. It's always filled with patients waiting. There's no air conditioning. It's 90 million degrees. There's this sign right there which tells the story about this waiting area. This is the outpatient department for orthopedics, urology, surgery, medicine A, B, and C, plastics, rheumatology, skin, nutrition, and physiotherapy. And importantly, they do have their rules. There's a dress code that includes no bareness of body, no dance hall fashion. That's what the waiting area in front of the hospital looks like. This is one of my favorite pictures there. That's the CEO's office right there. And I'd love to show that to our CEO. But it's a beautiful hospital. There's these beautiful gardens. They take great care of these old army barracks. So that's the army barracks where the patients are now housed, and there's beautiful gardens all around it. This is a sign that's in the hallway there that I took a picture of that's hanging on the wall. And I'll read part of this. Count your blessings instead of your crosses. Count your gains instead of your losses. Count your joys instead of your woes. Count your friends instead of your foes. Count your smiles instead of your tears. Count your courage instead of your fears. Count your good deeds, etc., etc. And that's hanging on the wall, and I think that summarizes what this place is all about. When we got there, this was the bypass machine they had. It was in an outside hallway, and it had not been used for a while. This was the cardiac surgery center. There was a building that had a sign, Cardiac Surgery Center, and when we walked inside, this is basically what we saw. So they had not done heart surgery there for a while. They had an old bypass machine. Now, right outside of that building is this beautiful garden. There's that tree right there. The other team that goes there now is the team from Great Ormond Street. They call that tree the Victor Tsang tree, because after Victor does cases, he sits under that tree and thinks. And this is just, it's such a beautiful hospital that just at that point was not doing heart surgery. Now, Jamaica is an interesting place because outside from the hospital, you can look up this hill, and up the top of the hill are the big houses where the rich people live. So unlike many places where the rich people live in big houses on the water, in Jamaica, the big houses with the rich people are up on top of the mountains, and the sponsors of our mission trip came from those houses. This is a view from the cardiac conference room, or the general conference room, or the only conference room within the hospital, and you can look out at the front entrance. Again, there's a wall with barbed wire surrounding the whole hospital. Over here, there's a security guard that stands at the front entrance with a semi-automatic gun. So it's a fortress, but it's a great hospital. And again, the whole place is fenced in. There's beautiful Jamaican art on all the walls in the whole hospital. We went down there in 2006. We went on our fact-finding mission to learn what we needed to do. We didn't do any surgery. Then in 2007, we went down, we did 7 cases, 2 ASDs and 5 VSDs, with a bit of a larger team. Standing next to me is the adult heart surgeon in Jamaica. At that point, there was no pediatric heart surgery there, and that adult heart surgeon worked with me on all the cases. And we brought a fairly large team because we needed to bring nursing, anesthesia, perfusion, critical care, the whole ballgame, as we started to partner with the Jamaican team and help collaborate with the wonderful healthcare providers within that hospital. So we had to bring a lot of equipment. That's a picture of all the equipment that we shipped down from Florida to Jamaica. It came down in these boxes on pallets. I'll talk more about what a pallet is in a minute. The nurses came down and worked with us for a full day to turn that ICU into a functional ICU to do heart surgery. And we continue to do this every year, partnering with the team. Our team that traveled down got a little bigger. That's us in 2010. In the back row, you can see a very young Mitch Cohen standing next to Dave Cooper. That was the first year that we did some electrophysiology down there, and Mitch actually did the first ablation ever in the Caribbean that year. Then by 2012, that's the group that traveled down. 2014, and you can see we have an adult heart surgeon named Vinay Badwar there, who came down to help us do some complex rheumatic mitral repairs on teenagers, because Vinay had some great mitral skills, and he helped us fix some rheumatic mitral valves on 14-year-old, 15-year-old patients. Also, Frank Scholl is in the front row. By now, we were running 2 rooms in collaboration with the Jamaican team, where I operated in one room and Frank Scholl operated in another room. My wife came on this trip. My daughter's in that picture, too. Then this is 2014. Frank Scholl is back with us again. We're sitting under Victor Tsang's tree in that picture. So a little bit of how this works. Every mission starts with the Joint Cardiac Conference, and the Jamaican team and our team all sit in a room together, and we work together and discuss all the patients and plan out. That's the first day, and then we make an OR schedule and figure out what cases we might be able to do. We maintain a pretty accurate database about all the cases. That's something we take seriously. All the cases are entered into a database. Our perfusionists actually maintain this database. In our home hospital, we use Cardio Access as our database, and our perfusionists fondly call this Cardio Access Jamaica. And again, that's the database that's sitting in the OR next to the perfusion machine. Every case we do on every given mission is entered, and all the variables are tracked so we can keep track of what we're doing and how we're doing. Down in Jamaica, we see some fairly unique clinical scenarios that I had never seen before I went there. So here's a young child with tetralogy who in the United States clearly would have had surgery before the age of 6 months. This child is actually 8 years old, and there's the clubbing on the fingers. So that's something I had not seen before I went to Jamaica. Similarly, severe failure to thrive. What makes this case notable is that this little baby is 2 years old. So this is a 2-year-old that weighed 6 kilos with a huge VSD, and we were able to repair that kid's VSD. There's wonderful caring families. This father traveled by bus over a 2-day journey from one end of the island to the hospital in Kingston to have his baby have surgery. He had nowhere to stay when he got to Kingston, and you'll see the families basically sleep on these benches outside the hospital because there's no place for them to stay when their kids get surgery. We try to create tremendous partnership with each team. So here's our cardiologist, Blaine John, working with the Jamaican cardiology team, and they do all the echoes together. They do an outpatient clinic together, a lot of knowledge exchange. Similarly, our anesthesiologists and their anesthesia team work together, and this is our form of within-program twinning. Cardiac surgical partnership, I'm operating there, helping the surgeon from Jamaica, with me doing the case here. But by the end of the mission trips, the Jamaican surgeons were doing the overwhelming majority of all of these cases with me assisting. Again, perfusion, our perfusionists work very closely with their perfusionists on a one-on-one partnership. Critical care and nursing, there's David Cooper and Jennifer Carapolucci working with the Jamaican ICU doctor. We worked hard to get good equipment down there. When our hospital bought new bypass machines, we shipped our current bypass machines down to Jamaica and got them a couple of new bypass machines. That's our perfusionist, Mike Papard, standing with great pride that we were able to successfully get these 2 perfusion machines through the customs services into Jamaica and into the operating room, which had its own unique set of challenges. There was clearly a cultural exchange. We tried to teach the Jamaicans about American football and the Tampa Bay Buccaneers, and we learned a lot about Jamaican culture and Red Stripe beer, so that was all good. There was a lot of good things that happened. In year 1, all the cases were done by our team, and we only did ASDs and VSDs. By year 8, 7 of the 9 cases were done by the local surgeon. There was increased role from all of the other healthcare members of the team in Jamaica. The local team by this point was doing 2 cases per week. Sherrard Little, their surgeon, had spent a year training in England and an additional year training with John Brown in Indianapolis, and by now he was back and up and running. There was really no non-complex cases like VSDs left for the mission, and we started doing more complex cases, neonates and single ventricles. Sherrard has shared with me a couple of slides about the overall history of heart surgery in Jamaica. So in the first 35 years of all heart surgery in Jamaica, there was 2,000 patients that underwent heart surgery. Most of this was adult valve surgery and PDAs, and a quarter of it was congenital heart disease. But again, most of this was PDAs more than any other form of congenital heart disease. During these first 35 years, of the 532 procedures done, 80% were performed by visiting teams. And this is a graph that shows the work done by the local team in blue, the work done by the visiting teams in green, and the overall number of cases. And in 2008, after a few of our mission trips and Sherrard coming back home, for the first time the local team began doing more congenital heart surgery cases than the visiting teams, which was a notable accomplishment. And then from 2008 forward, 2009 and after, the local team consistently did more cases than the visiting team. So they're doing now 2 to 3 cases per week, with the mission teams coming down to just help with complicated cases. This is the overall transition from the beginning up until recently. And the complexity has also increased, as shown by this slide, where in the beginning they were doing all patent ductus arteriosus surgery, but over the course of time, they pushed their boundaries, started doing more and more complex cases. No hypoplastic left heart syndrome is cared for and operated on in Jamaica yet, but short of HLHS, most cases are done. The bottom line is that now the majority of cases are done by the local medical team, which is something that we're all very proud of. This is Sherrard Little and I standing in front of an empty field, and this was at the groundbreaking ceremony of a new cardiac ICU that was built in Jamaica with funding from their cell phone company Digicel in collaboration with funding from Usain Bolt, the fastest man in the world, and Shaggy, who's a musician. And this is their new cardiac ICU just before it opened. And that was built with that funding, and that's now where heart surgery takes place in Jamaica. They have a couple of ORs, a 6-bed ICU, and a cath lab. A couple of quick important lessons as I wrap this up. First of all, every life saved is a life saved. And going overseas on a charitable mission elsewhere and saving lives, even if nothing else is done, lives are being saved. And our slogan that we had on our t-shirts at that point was 10 lives per year times 20 years equals 200 lives. Like that one. And that's some mothers with some of the babies we operated on. But more importantly, partnership, teamwork, and sustainability saves thousands of lives. And that's a picture in the waiting room at Bustamante Children's Hospital with a variety of family members and parents. Besides every life saved is a life saved, I learned about the differences between equipment and disposables. Equipment is the bypass machine. Disposables are tubing, oxygenators. Both are necessary and require different strategies to procure. I learned what is a pallet. So for those of you who don't know, that's a pallet. You can use that thing to bring equipment. We can bring, on that particular pallet, 2,800 pounds of medical equipment or 1,272 kilograms of medical equipment. And if you pack up about 8 of those pallets, you got enough stuff to do a mission and operate on 10 kids. Collaboration across NGOs is critical. So our mission collaborates with a number of NGOs, our foundation, Cardiac Kids of Florida, Chain of Hope based in England, and Gift of Life and the Rotary. And these groups all have come together to make this in Jamaica possible. Collaboration between different mission teams is important. So Great Ormond Street goes there in the fall, we go in there in the spring. We share equipment, we leave equipment for each other, and if a child needs a second stage, the other team would do the second stage. So we work together. Victor Tsang has been a huge part of that collaboration. Alternating visits every 6 months, shared equipment, common patients. The collaboration within teams is important. This is where I talked about partnering nurses with nurses, cardiologists with cardiologists, anesthesiologists with anesthesiologists, etc. We learned what equipment is truly necessary, and the best example I can give for this is back home I had immediately to my right a near-infrared spectroscopy monitor, or a Solmonetics machine, or Covidian. We'd go on bypass, we'd look at that, we'd make sure that the nears were okay, and I was just always so used to go on bypass, look at the Solmonetics, make sure it's okay. There's no Solmonetics in Jamaica, it just doesn't exist. So you learn that, well, that's something you're going to do without. In the final analysis, every life saved is a life saved. Partnership, teamwork, sustainability, that's what can save thousands of lives. And twinning has a lot of different meanings. There's twinning of programs, but there's also twinning of a cardiologist with a cardiologist, a nurse with a nurse, a perfusionist with a perfusionist to help with the training. And that empowers the local team with, and our goal was to create a sustainable program in Jamaica where we're helping them. And over the course of time, that's what happened. And it's secondary to the wonderful doctors, nurses, and perfusionists within Jamaica. And you know, with that experience now, the majority of cardiac surgery in Jamaica is done by the Jamaican team, but they still have a huge need for equipment. They don't need a surgeon to come help anymore. They need the equipment that we bring. And I'll wrap it up right there. This is one of my favorite pictures. It was our 3rd year down there where they brought back about over half of the patients we had previously operated on for a little reunion. And that's what it's all about. And I think some of these lessons that I discussed today can be applicable to some of the discussions that we're making about program growth and development. Thank you.
Thanks, Jeff. Our next speaker is Dr. Uvi Anakboya. I'm sorry, Dr. Michael Okechko is not here. So we're going to skip his presentation and go to Dr. Uvi Anakboya from Ife, Nigeria, setting up of the cardiac congenital heart surgery program, the Nigerian model.
I thank the World Society for the opportunity to talk about how we have tried in Nigeria to set up a congenital heart surgery program. I work in Ile-Ife, which is a very small community, and also serve as the president of the Association of Cardiovascular and Thoracic Surgeons of Nigeria. I'm going to be talking a little about our initiative in establishing congenital heart surgery program in Nigeria. Welcome you anytime to visit our university campus. I have no disclosures. I think it's important to talk about the Nigerian child. Nigerian child is located in a very special circumstance, located in a country of about 200 million people. We have a very high birth rate, also a very high neonatal mortality rate, one of the highest infant mortality rates in the world, and a very high under 5 mortality rate. And I think one of the things that contributed to all of this is, I think, the communicable diseases and the emphasis on communicable diseases without realizing the impact of congenital heart disease in our patients. We have one of the highest under 5 mortality rates in the world. And in Nigeria, we have over 55,000 children who are born every year with congenital heart disease. And as if that is not bad enough, there's no health insurance, and over 70% of our population lives on less than $2 a day. So this is the typical Nigerian child. Tetralogies that we see almost always come with clubbed fingers and clubbed toes. So we have 55,000 children who really are born with this condition. So this was a question asked me by members of the department in Israel where I did congenital heart surgery fellowship in 2010. What options are available for care for the children in Nigeria? At that time, we didn't really have much options, as I will show much later on. But these are the options generally that we have for care. One is to ship our patients out of the country, east, west, north or south, through whichever means of transport. The second option is visiting foreign cardiac teams, and many of our centers started this way. And this is quite useful to meet immediate needs of children who cannot afford surgery. But unfortunately, in our country, many end as huge media events without much translation into programs. And again, even though they are supposed to be free for the patients, they don't come in cheap, because many of the hospitals, especially government hospitals, do not have government funding to be able to cater for this treatment. So we have problems with the first two options, which is shipping the patients out or dependence on foreign missions. Of course, we know that with the COVID, natural disasters and political upheavals, these are negative things that interfered with travel. So those who dependent on the foreign missions couldn't have the teams come during the period of COVID. I remember while we were transiting, we had a mission visit planned by my trainer in Israel, and there was just a political upheaval in Nigeria at that time, and they couldn't come. The children had already been admitted. We had to send them away, unfortunately. So, but these are some of the things that dependence on options 1 and 2. Of course, one of the things we realized was that in some programs, some visits in Nigeria, we have uncertain skill levels and experience of visiting teams. This is a reality that we've come to see. And of course, there's no clear pathway for local team development for some of the missions. The other thing we're seeing is that some of the missions, when they come, do only the very simple cases, and which is understandable because they want to have good results, it's good optics, and so that they can present that to their sponsors. But who does the difficult cases then? Of course, to further add to the complex mix is different visiting teams. So there's no continuity with the local surgical teams. You have different surgeons, different anesthetists coming for each visit, and so there's no way to really track the training. And of course, for the option 1, which is shipping the patients out of the country, we have a loss of national revenue. We are not a very rich country, but in spite of that, we lose up to $2 billion every year to medical tourism. I think one of the last things I want to talk about on this is what I call the mission addiction syndrome. It becomes an addiction for the cardiologists and for everybody. The hospital management is waiting for the next time the mission team is coming. Again, in a cultural way, one of the ways this affects us is that our population tends to see the mission teams coming, they are fairer skinned people, and so they tend to believe that those with their own color of skin cannot do the surgery. And that becomes a big problem when the teams want to transit. So the other option which we are trying to do right now is to develop a local heart surgery team. And this, of course, involves training of the whole team and purchase of equipment, as well as other accessories. Of course, establishing a building to get this done. I'll just try to go through a little historical perspective in Nigeria. First open heart surgery took place in the southeast of Nigeria, and it was an ASC closure by Magdi Yakub, who came down to work with the local surgeons there. 4 years later, we had in Ibadan, which was in the southwest of Nigeria, a completely local team that did also an ASC closure. And these programs had varying degrees of success, but by 2000, these programs are really grounded almost to a complete halt in these two centers. I had the great privilege of meeting with Sir Magdi Yakub a few years ago in South Africa at the conference. So in 2013, I discussed with my trainer in Israel, and he came down with his whole team to do first open heart surgery in a private hospital in West Africa. Now, I work in a public hospital, but our public hospital wasn't ready for cardiac surgery at that time. And so we moved to the private sector to do the surgery. So this was a 1-year-old child who had DORV, subaortic membrane, and this was the child at the end of surgery. We did a few cases after that, and this was the team with my trainer and some of the local team there. So we eventually developed partnerships, eventually with his hospital in Israel and the hospital in India, not only in the private sector, but now in my own public hospital where I do a lot of the work I do. And our teams have been trained in varying places. Of note is to emphasize that even though most members of our teams had trainings outside the country, right now a lot of the training is taking place within Nigeria for most of the cadres of staff that we have in our team. So what we're doing is developing local capacity. Our trainers are also our mission partners. So we're not getting partners who we don't know, who don't know us, who have never worked with us before. So they were coming 3 times every year, and we set a realistic timelines of a transition into our indigenous program. It took us 2 years to make that transition because we had more missions 3 times every year, 2 by the teams from Israel and 1 from India. We carefully selected our cases, and we had to develop a philosophy, which is not really, it's maybe a little alien to our own culture, but it was a saying from John F. Kennedy that inspired every one of us in our team. And I'll just say what he said in 1961. We choose to go to the moon, not because it's easy, but because it's hard. Because that goal will serve to organize and measure the best of our energies and skills. And because that challenge is one we are willing to accept, one we are unwilling to postpone, and one which we intend to win. So this is really our driving philosophy in the midst of the difficult scenario situation we walk in. So I'll just share a few data from our national database. We have a national database for cardiac surgery, and this is, and you can get it, it's in the Nigerian Open Heart Surgery Registry. We hope to be able to work with the World Society and get this all the data updated, uploaded there. So we have 2 main institutions right now on this database who are doing most of the cases, the private hospital, the Tri-State Group, and then our hospital, and then LASUTH in Lagos. But in terms of the kinds of cases that are being done in these institutions, you find out that just 2 of these institutions, my own hospital in Ife and the Tri-State Group, do most of the pediatric and congenital heart cases. The pediatric and congenital heart cases are the ones in green. In spite of the fact that when you look at the total number of cases, the spectrum of cases in Nigeria, most of the cases are congenital, and that's why you have this very long graph bar there. So most are congenital. So we have moved in our own hospital and in the Tri-State Group, as well as in LASUTH, that does mostly adult cases, but some congenitals also too. We've moved from this model through this, where we're now working with trainers assisting us, to this, where we have a completely local team doing most of the cases in our country. And this graph also from the National Open Heart Registry also shows us the transition from mainly foreign visiting teams in 2004 to the situation where now almost 90% of our surgeries are done by local teams. So is this the El Dorado? Have we arrived? I don't think so. We still have a lot of challenges of funding, challenges of low numbers. And I say we have no nitric oxide in the country. So that, of course, that affects the kind of cases that we do. We don't do neonatal surgeries. We do mostly cases who are above 4 kilograms because we have to work with what we have available with us. So going forward, our association, in trying to develop congenital heart surgery in Nigeria, is organizing, instead of having foreign missions, is organizing local missions to other hospitals within Nigeria to help to develop the programs. And like Drisi went to Sokoto, we also went to Sokoto last year, and we plan a mission next month to Benin City to help to start their open heart surgery program. That will be the first open heart surgery program to be done. And we encourage foreign mission teams to liaise with the Axon group, because it's a very robust group with all specialties in it. We need to have a very clear pathway for training and establishment of independent Nigerian cardiac surgical teams. These are just pictures from our visits to Sokoto, where we operated on some very wonderful children. And this was the ICU meeting immediately the day after surgery. And then we had a picture with some of the children we operated on. This was the team that went to Sokoto, and we believe is the first of many local missions that we're going to have in our country. So, question is this. At the beginning, we showed a picture of this child who came to us with a VSD, was 2 years old, could hardly stand, could not walk. So same girl, 6 months after VSD closure. The great transformation. And the parents sent us this picture. We were so excited. So I just dedicate, anytime I present about our program, I just dedicate to our wonderful patients, and of course to my trainer. Thank you for your attention.
That was just a very inspiring talk and great work. Congratulations. The next speaker will be Dr. Al-Jassim. I hope I don't mess this up. Al-Jassim from Dubai in the United Arab Emirates. I'm sorry if I mispronounced your name. Implementation of pediatric and congenital heart disease treatment program in resource-limited countries by Nabadat. So that brings us to Bistra. Our session today will be closed by Bistra, who will present her talk on Global Initiative for Children's Surgery. And there's perhaps, as I've introduced Bistra to my family and others from my hometown, I say there's perhaps nobody that knows more about the business and science of NGOs and cardiac surgery than Bistra. And I've heard her speak in many settings. She's a dynamic, powerful speaker with tremendous knowledge. And we put a lot of thought into who it should be to close this session. And we thought Bistra's the perfect person to close this session and lead us into the panel discussion. So thank you very much, Bistra, for joining us.
I'm sure there's someone who knows more than me, but thank you. I think I'd like to thank the organizers for inviting me and for a wonderful meeting. And I guess it is a privilege to close, and I'll try to stick to my time so we can have a good discussion. I will be speaking about the global recommendations that I was part of developing, global recommendations for planning and development of pediatric cardiac services. I guess it's a similar project, but I'll try to point out what the differences are from the first presentation we heard. And this was part of a initiative of the Global Initiative for Children's Surgery, My name is Bistra. I work for Children's HeartLink. Most people actually know Children's HeartLink as an NGO that builds capacity around the world, and this is our primary purpose of existence. We have long-standing partnerships with hospitals to develop them as centers of excellence. However, I speak here in my role more in advocacy, which is a new area for us, and trying to work with governments to get them to invest more in policies and health policy specifically around pediatric cardiac care. And not just governments, actually multilateral organizations like the WHO as well. So first we, I think, saw maybe one of those slides, but just to remind us what the burden of congenital heart disease is globally. This is from the Global Burden of Disease study. And I just want to point out the bottom two numbers, that 96% of the mortality is in low and middle income countries, and 70% of that mortality happens in infancy. And so this shows us where we need to be working. This is where we need to be investing our time. This is where we need to be putting our efforts, clearly developing more capacity in low and middle income countries and helping them get to the point where they can be treating infants and newborns. Same study, if you look at actually their data, I'm sorry it's a little bit busy, but I'll explain it. This heat map, again, shows the causes of death in children under 1 year of age. And just want to point out, the third row is congenital heart disease. congenital heart disease is a big contributor to mortality in infants across the board in poor countries and in rich countries. And you can see I tried to actually select some of the countries that people I've met at this meeting. And the first column is the Middle East and North Africa region, and the last column is Africa, but there's a number of countries. I've highlighted Morocco since we're here. And in Morocco is the third cause of infant mortality. So it is something that we shouldn't forget, and I think that's an important number that we need to be bringing out to policymakers as we have discussions. So Children's HeartLink few years ago published a series of policy papers called the Invisible Child series, and in that, with that, I think started our advocacy work, really. We identified 4 areas that should be a priority of investment for all stakeholders around the world, whether they're governments or funding organizations or professional societies. Or hospitals, actually, individual hospitals. But one would be increasing the capacity for care for children. Next one would be to build a pediatric cardiac workforce, closing the data gap, really knowing where our burden is. And I think the Global Burden of Disease study for congenital heart disease actually brought a lot of knowledge around that. And financing pediatric cardiac care, which is the most understudied area, trying to understand healthcare financing and health financing from a government perspective is a complicated issue. So I think I'll speak more about the top 2. The project that I will discuss will relate to the top 2, but the Global Initiative for Children's Surgery is a voluntary organization. It's an organization of people who practice in global health, but also people who practice in pediatric services, mostly surgical services, but it's multidisciplinary. There's a lot of organizations and actually some professional societies who are members of it. And they have several goals by bringing this group together with actually policymakers, so government representatives, to analyze data, to develop recommendations for national priorities, and to bring together resources to address those priorities. So they've had some publications. One is the optimal resources for improving surgical care for children, which did not include a lot around congenital heart disease, but it did include some around birth defects. In a number of different papers. But I will specifically speak about the experience of the cardiac care, cardiac surgery working group, which was started in 2018, and I was part of it. Resumed the work actually in 2020, early in the pandemic. And the goal was to develop global recommendations for planning and development of pediatric cardiac services. So what are the minimum necessary requirements? And really giving a roadmap to governments, to people, when you want to develop pediatric cardiac services, where do you start? What do you think about? It's not just about surgery. We have to be thinking how our patients are coming to the surgical center. And if that referral pathway is not successful, the surgery often is not successful either. And so some facility planning recommendations, as well as population level recommendations for policymakers. The cardiac working group is actually bigger, but these are the kind of the 4 individuals, including me, who I worked with, Dr. Babar Hassan from Aga Khan University, as well as Dr. Munir Amanullah, who is a surgeon from the same university, and a medical student they work with, who did a lot of the literature review, as well as the writing of the recommendations. And we received an input from all of the individuals on the right-hand side of the screen that you can see. Many people have seen it. Just want to point out the Child Health Task Force is actually non-surgical, non-cardiac group, but these are people who work in childhood healthcare, providing advice to governments or sometimes actually government policymakers. It's a global organization that is brought together actually by UNICEF. And so that survey that we were trying to get input into the recommendations was sent to them as well. So what influenced the development of these recommendations? I want to point out the NHS England pediatric and congenital heart disease specifications was very influential, as well as the Australian national standards of care for childhood onset heart disease. And I want to point out that the Australian actually document is really good because it actually includes rheumatic heart disease, since Australia has a lot of heart disease, rheumatic heart disease as well. And that stems from National Health Plan, a strategic plan that the Department of Health Australia has. And I just learned today that Ireland also has a very good program, so we definitely intend to look into it. Another piece that influenced our decision-making was the pediatric cardiac care continuum that we developed for Children's Heartland had a project supporting the government of Kerala. Kerala is a state in India. And we helped them develop actually a very good referral, screening and referral program, which that government had a goal of reducing infant mortality, knowing that congenital heart disease contributes a lot to infant mortality. And so this was part of a project of several years. We just published it last year. But this care continuum again points out the fact that all of these areas have to work out well in order for the treatment in a tertiary center to be working out well as the follow-up. So all of these pieces have to be in place, especially for infant and neonatal surgery. And last, since this was the document intended to be viewed also by policymakers, we had to look at how facilities are classified typically in a healthcare system. And so there are two classification systems. One is the disease control priorities, which is a World Bank document that gets updated, developed every about 10 years. And the WHO also has a classification. And we actually ended up using the DCP3 because we felt that fit better with what we were trying to do. So what we came up with was 5 levels of pediatric cardiac services. And surgery happens only in the last 2, actually. The first 3 levels are pretty much about referral, when the top one is a health center. And I'll give examples later, but just want to show that we actually looked at these, 7 domains: that age and complexity of the patients, whether there's general anesthesia. Most of these do not have general anesthesia. What are the human resources necessary in that particular facility? What are the required skills? What infrastructure needs to exist, equipment and supplies, as well as quality and safety, which was mentioned several times. I'm very happy to hear it. Quality and safety is really understanding our outcomes, which is so important to our field. So quickly, I'll just show you the pediatric cardiac services level 1 and 5. And so you can see at level 1, we're pretty much talking about screening and basically triaging patients. There's not going to be any diagnostic capacity at that level, while at level 5, we will have the full range of services. And we haven't spent time defining them because that was not the point of this document, is what does cardiac surgery necessarily have to have, or what does the intensive care unit? There's more detail in terms of we are recommending to have dedicated intensive care, but I think that was not the point of this document. The point was to show a roadmap of what is the best practice, what should be the best practice for pediatric cardiac services development in a healthcare system. And so you can see that once we get to the last level, there's a lot more requirements in terms of what human resources are needed, what are the skills that have to be developed by everyone on those teams, as well as the quality and safety. So next steps for us. We are still collecting feedback, so if anyone's interested, here's our survey, or email me and I'll send you a link. We are also thinking about developing this population level recommendations. I'm actually very interested in a discussion. I think it started with the first talk today. What is per population? What is the best number of centers you need to have? How many cases should that center be doing? It's probably going to be different in India or in Nigeria than what it is in the United States today. So I think that that's a very important piece, again, for policymakers. We are drafting this as a manuscript, and we hope professional societies would be interested in endorsing this as they see feasible. Obviously, understand that they would want to develop something different. So this is from me, and I appreciate the opportunity to tell you about it.
But Bistro, why don't you stay there?
Sure.
And that'll give us the chance to open up the panel discussion. And we'll start with our executive director, Krista, who's going to walk up to the microphone. And we're actually finishing on time by some act of God. So we have plenty of time to have a panel discussion at a very comfortable pace.
Bistro, nice presentation, and I really congratulate you for your life work in this area to help the kids of the world, and heartening. And I'm kind of brainstorming here. The World Society was established in 2006, but when we wrote the Constitution, we had also a Council on Services. And we had some discussions in Istanbul of that council, but it kind of, I shouldn't say fell apart, but really became dormant. And this Council of Services, the way we had imagined it, is to work exactly in the area that you're demonstrating. But having been so busy in developing so many other aspects of the activities of the World Society, you can't fight all the battles at the same time, especially when you're trying to really be born and survive as an organization. But this brings the issue of, with the largest professional organization representing the congenital heart surgeons of the world, we're more and more powerful and more significant. But we have, as an organization, left a void in this area. And when there's a void, others sort of take that void and take that leadership. It brings the question of representativity. And we've had this conversation several times, is that policies are being drafted in different forums, in different organizations. What is the representativity? I understand that there's a few surgeons from Pakistan that were involved in this surgery initiative, with some informal input from a few individuals that you listed on the right. But there's no there hasn't been a systematic discussion within our organization, the largest organization representing congenital heart surgeons, to define these policies and these guidelines, then eventually will be endorsed, hopefully on a global level. How do we bridge these two solitudes? It's frustrating for me, because the dreams are the dreams, but then the realities are realities. But it's really time that we come together, and it's really time for the World Society and the African Society and the other sister organizations take the leadership to discuss this in a systematic way, come up with definitive organizations which actually are alive, they can be modified over time, and then reach out to the other stakeholders, governments, international organizations, World Health Organization, etc., etc., etc. We have to start that conversation, and the World Society has to take this leadership finally. So I would like to announce that this Council on Services that has been really dormant is going to be led by our second Vice President, Nestor Sandoval. We will set up this, we will populate this council. We would like to invite anyone that's interested from all parts of the world to participate, including you, Bistro, and some of the other people that are very interested. But we have to somehow come together and come up with policies really endorsed by the congenital heart surgeons of the world. Otherwise, it's not going to work. You can make all the documents you want, but then somebody's going to say, well, that's sort of Children's Heart Link on this other organization or the other NGO. Everybody means well, really. I mean, everybody acts in really good faith. But we're like little lights little stars in the universe, and we have to really come together as a powerful voice. And until an organization like the World Society and other sister organizations take up this challenge, it will continue to be very kind of disparate, scattered, and we're not going to make the same impact as we could if we come together. So it's just a plea for really figuring out a way not just us, but together, how do we do this? How do we come up with this definitive blueprint for the future?
I can't say I have the answer, but first, just to say that this is not a Children's Heartland project. It's a project of a number of individuals, and I just happen to work for Children's Heartland. And this does not exclude any of the work that you're saying needs to be done. As you can see, it's not the complete picture of what is absolutely necessary. It's not the guidelines that exist by the European Society, nor it's the same like the NHS England, which I read on a regular basis. But I have to tell you, it was born out of also frustration that we have meetings. I have meetings with people who are constantly wondering, where do you go? What should we do? What is the roadmap? We are starting to talk to governments and trying to give some recommendations. And so I think the point here is not to say this is how it should be, but the point is to say this is the direction in which you need to go. And these are the components you absolutely need to be thinking about, which are quality, multidisciplinary care, appropriate referral, screening on time, focusing on newborns because it contributes to infant mortality. I would say that's the best way to do it. But I would be very happy if the World Society takes this on and takes it to the next level. So Nestor.
I think the important part of bridging that gap, Christo, Carl's talk focuses in a very granular way on provision of cardiac surgical services, which of course is key to the success in any of these very difficult circumstances. But it is a uniquely surgical perspective, and there's a lot more to the scenarios and to the needs than just what does a cardiac surgical center look like. And I think this is what this document is speaking toward. It's about population health, it's about national infrastructure, it's about governmental policy, and advocacy work is really about that. And my own view of the situation is that both populations of authors, if you would, have important information, important insights that the others don't have. And so I think it's crucial that we begin to figure out how not to sit in separate camps, but instead work together and not demand to be the preeminent force in the dialogue or the creation of a document, but instead, get to a point where Idrisi and his conversation with the African Union can have data-driven and thoughtful documents to create a convincing argument, because advocacy in developing world setting is absolutely crucial. Not everybody has a Magdi Yaqub to attract philanthropic money, and so sustainable, lasting support is key to it. We can have as sophisticated and as detailed a description of what a cardiac surgical center should look like, but without the recruitment of population health people, policy people, etc., it's going to be very difficult to advance the ball. Lisa.
Great, thank you very much. Just to thank all the speakers in the session. I really enjoyed the session, and thank you to the organizers for having it, because it really is critical a conversation that we need to have. I would still like to echo what Zohair said when he came up. He said this is all in the end about funding. And what we need to try and do is obviously advocate to our governments and to our policymakers to put money behind this whole project. But what I wanted to hear actually from my colleagues from Nigeria, there was a wonderful presentation, and from Drissy as well, is what are the innovative funding mechanisms that you've both used? Because both of you actually have incorporated your programs within the public service setting. It's very appropriate. I think Darshan mentioned, if you've got a public service, which is a private service, which is where the major program is, and you incorporate public, that's sometimes a little bit easier to work with. When it's mainly in the public service, that is far more difficult. So I was just wondering if we had some additional lessons either from Nigeria or from Morocco to guide those who are trying to start those services, but based in the public service, because ultimately that's where we want to go. We want to build the services that's going to address most of the population. Thank you very much again.
Thank you, Lisa, and thanks for your leadership in this area as well. Drissy is going to be able to initially respond.
Yeah, thank you, Leslie. In our setting in public hospital, there is institutional fund. Every year we have a budget, and the hospital buy all the supplies we need for our program. And according to our plan, let's say we are going to do this year 300 open heart, we need 150 valve, we need 100 bypass circuit for children, we need this for ECMO, we need this for ECMO. And this is, the budget is done, and the hospital buy the supplies. Sometimes the central pharmacy is not well, the dotation, or is not well, there is some delay in purchasing all this disposable. At that time, patient maybe is obliged to buy something outside the hospital. But in general, since the last, I think, 12 years, we have a sustainable supplying the hospital with what we need to do cardiac surgery. We are doing adult, pediatric, neonates. Now in pediatric setting is really in public setting is really challenging. We still trying to have a sustainable program, but I think and patients do have public insurance. So with this public insurance, they can accede to the public hospitals. So this is the way we're doing it. Of course, there is a private. The private is functioning by itself.
Thank you, Drissy. Giovanni.
We had a confirmation this morning that many missions are very successful around the world. But as I said yesterday, they're all scattered, and we need an organization. So the most important thing is money. I think the rest of the world should decide whether children with congenital heart disease in low middle income countries should die or should survive, and that it is in a very big program that should, I think, be sustained by WHO. I did apply a few years back at WHO for my mission in Eritrea, but of course it was a small mission, and so it was rejected. I think that it is important that WHO, someone should apply to WHO, perhaps to support, let's say, continent Africa to start with, and have organized, missions, as I said, under the umbrella, perhaps, of the World Society, and with the funds on WHO, to have a serious program, a well-organized program to control all the missions in a particular region and make those missions, to improve for the best of the children.
I know, Beaster, you know more about it than I, but I mean, the emergence of non-communicable diseases on the World Health stage has, happened in recent years, and So perhaps we can make some inroads in that. Do you have any thoughts about that?
I can't speak to the funding capacity of the WHO. My understanding is that they don't fund a lot. They fund at a, maybe provide some funding at government level, but they have a very important role. And I'm going to share my dream here. My dream is that we will have these recommendations, not these particular, but some sort of a recommendation that the WHO will develop that relates to pediatric cardiac services. I would say that is the best role for them. They develop normative documents in health policy, and that a lot of governments listen to what they do actually and take them seriously. Many governments develop their national health plans based on those normative documents. And right now, everything that's in child healthcare at the WHO and newborn healthcare, infant care, does not include congenital heart disease. I would say maybe with rheumatic heart disease, Lisa can speak a little bit more about it, but even with rheumatic heart disease, there hasn't been too many inroads done. Everything has been achieved by external organizations. So that will be my comment.
Thank you very much, Bistra. I'd like to first, my friend on the left from Nigeria, and then our other colleague from Nigeria.
Yeah, just to address the issue of funding for our patients, there's no government support really for our patients. So we have to depend, there's no central government policy, there's nothing as at now. So we're just engaging, we've been engaging the government and we'll continue to engage them to see how they can take care of these children. So all we have to do, all we do now is based on NGOs, charity organizations within Nigeria. And then in some instances, we have some of our mission foreign partners who, for an example, is in Lagos, for instance, where they used to have this group called Cardiostat that used to do some missions in Lagos. Now they don't come again. What they do is to send consumables and other materials, even hardware, heart-lung machines and ECMO machines. That's what they do.
Thank you, Dr. Onakboya. And also, I just want to tell you, your talk today was great. Thank you. It was really great.
Okay, thank you. Please, I still want to emphasize that issue of lobby. I think we need to be strategic and deliberate about it, especially with the African society. We should target, especially the African Union, African Development Bank, and then the national associations can then come from at the national level. But I think we need to be strategic on this because it will do a lot in that respect. And then the second thing is about the issue. Another challenge is sustainability in terms of procurement of the consumables. The consumables, based on the demand and supply principle, the consumables tend to be very expensive. I think if we can have some regional bulk procurement strategy, where, for example, if you have in West Africa, all the centers can be able to negotiate, and then they can have some consumables which will be relatively cheaper, and then it will improve the access as well. And then also the missions, most of the missions seem to be targeting the public sector. But again, we have a lot of challenges in the public sector, and a lot of private initiatives are coming up. So I think we should be a bit pragmatic so that sometimes we can even use the private sector as surrogate or bridges to the public sector so that we can improve the capacity of the private sector, and then with an arrangement that they will also extend the training and expertise to the public sector. And lastly, I think we should also be multimodal in approach. We may not have to take one strategy alone. We can deploy different strategies. Like in our setting, I'm based in Kano, which is in northern Nigeria, about a 14 million population city. So about 6 years ago, we started a plan for the heart center and the project. Initially, we had to even sponsor the project from our pockets. Finally, the hospital came in, and because of the COVID, about 2 years ago, we had one of the local politicians, a senator, who also bought in the idea. And then as it is last year, he got a government support, about $2 million to build the infrastructure. And then we are getting also one of the philanthropists, one of the businessmen who will likely purchase all the equipment. And then we also registered a local heart foundation, which now some of them have even pledged to support some of the training. And we're signing an MOU with Professor Bumzebra for the retraining and training, and then also the missions. And then we're also engaging the multi-sector engagement, because just 2 weeks ago, we had a virtual stakeholder engagement, and a lot of media, civil society organizations were in. And in fact, in the next 2 weeks, we are planning to visit the head of the National Health Insurance Scheme and talk to him about the payment models and all that. So I think we can employ multimodal approach so that it can facilitate. It's a bit complex, the situation, but we have to be strategic in that. Thank you.
I would comment, these are many great ideas you had that I enjoyed hearing and that are very thoughtful. You should write this. The World Journal would publish this, and other people would learn from it.
Thank you, sir.
Alexis.
Alexis Palacios from Mexico. Thank you very much. I think that the complexity of the problem comes from the fact that there are so many countries, so many different problems in any country, that the solutions are different in every place. So I think what Bistro has done and guided with all these guidelines is very important. I think we need to set guidelines and some goals to focus, and each one can go there in the way they can. So, for example, I come from Mexico. It's a low and middle income country that fortunately has a little bit more of resources than other countries, but we're still not where we would like to. So when I trained in the US and when I came back to Mexico, I just identified how the Americans do to make surgery successful. And I identified 3 or 4 things. So fully committed physicians and nurses to a single program, decent payment for them, high volume of patients, and quality control systems that we don't have many times. And here I want to talk about what Dr. Reddy said about this private and public model. One of the main problems we have when in some countries that already have programs running is this fractured system between public and private that cannot, it's impossible to get high quality systems. So what we developed was a hybrid program that it's amazing how has helped us improve the quality of care. So I think that setting the guidelines and goals for everyone, and then try to help each other how to reach these goals and accomplish these guidelines. It's a very important thing to do.
Thank you very much.
Thanks, Alexis. Alexis has written up his experience in Mexico City, both twinning with Texas Children's Hospital, but the public-private partnership model, which was very successful. He's being deferential, but I'd encourage everyone to read that manuscript in the World Journal to learn more about the public-private partnership and aspects of that. Ahmed.
I just want to make 3 very quick points, but they'll sort of merge into one basic thing. The first thing, which Alexis also mentioned, is that not all low to middle income countries are alike. This is very unfortunate. I would quote George Orwell, all animals are equal, but some animals are more equal than others, unfortunately. So I think it's a bit of an oversimplification to treat all of the low middle income countries alike. But there are some of these countries who are a better vessel to initiate quick wins, not necessarily the richer of these countries, but I think we need to capitalize on that. Point number 2 is that what you've mentioned, David, about Professor Yacoub. I think because this is a room of cardiac surgeons and very intellectual people, they know who Magdi Yacoub is. I think for the Egyptian lay person, and these are the ones who provide most of our donations to them, Magdi Yacoub is just a celebrity. They compare him with Mohamed Salah, the Liverpool football player. And I think every country has some sort of an icon, doesn't necessarily have to be a cardiac surgeon or even a doctor. And there have been some examples mentioned with Eugene Bolt and Shaggy and others. So I think this is quite an important part, is to have advocates from outside the medical community that the lay people can identify with, that will give us a bit more credibility to whatever actually goes on during the establishment of these centers. Now, my final point is that I believe, from our experience at least, that starting off going to governments and politicians and asking them for money, or telling them that here is the whole plan and blueprint of what you need to do, it sort of stirs up egos, at least. And again, to the point that I'm trying to make of initiating quick wins. And I think Reddy also, he said, just start the program and grow into it. I think after you've made some quick wins, it makes it easier to speak to the governments and politicians, because they'll be willing to listen to you if you give them a chance to piggyback on some of the initial wins. Then they can pick it up, improve the funding, and call it their own.
Thank you very much. It's 3 good points. President Kirkland.
Well, I'm very impressed with the remarkable progress, organization, application of skill and dedication that's occurred in Africa that we've heard about today. But as we all know, it's very, very complicated, and each organization needs to be realistic about perhaps what they can contribute. So the one thing I would say is that whether it's governmental agencies or advocacy groups or others that are applying pressure for financial resources, they respond to a level of seriousness about the endeavor. And I think Giovanni was referring to this correctly when he talks about the number of groups that need to be seriously involved in a locale, NGOs which are involved in sort of tourism surgery. I think Jeff described very nicely how that can be addressed, but it's all about a level of seriousness. And so I think, Krista, you were asking about some concrete things that one can do. And to me, I think 2 things that the World Society could do, and I think Jim St. Louis has alluded to this, and we talked a little about it yesterday, is 1, quality assurance is critically important to that level of seriousness. So if it can be organized, and this is realistic, that whatever the level of detail in the data, that uniformly the African community, congenital cardiac surgery community, can provide data, which we would then absolutely commit to providing reporting and analytics, which would be appropriate for the center to look at quality. And the second thing that we would be happy to commit to is that if there is interest continent, not only, of course, in Africa, but elsewhere, but specifically in this discussion, Africa, of attending the World University, we would be happy to set a standard of sort of a knowledge base, not technical, of course, but a knowledge base in congenital cardiac surgery, which could be measured, which could be evaluated. There could be testing, examinations, and we would be very happy to commit the time and resources to do that. But there has to be a level of seriousness also on the part of the congenital heart community in Africa to participate. So if there is that level of seriousness, I think the World Society would absolutely commit to those 2 concrete examples, a level of baseline knowledge that could be certified and a quality assurance that I think would contribute to a perception of seriousness, which perhaps would facilitate leverage for further financial investments.
Thank you very much for those comments. Those are powerful comments coming from our president, and it seems like there's two direct deliverable ways that the world society can potentially contribute in collaboration with World University, one with quality assurance and one with sharing of cognitive information and cognitive testing associated with that information. I think let's go through. We have two more questions and then we'll have some closing comments.
It's Hisham Shawki from Cairo, Egypt, another area in Egypt. I'm just continuing on what Ahmed was saying about the progress of cardiac surgery in Egypt. Of course, the presence of Magdi Yaqub Center in Aswan made a breakthrough in the pathology and in the number of patients. But I have to add two things. In Aswan, they're doing around 600 to 700 kids a year. And we're doing in Egypt around between 4,500 and 5,000, which is a number. I know every country have a different policy, and I think what's a breakthrough in our policy in Egypt was maybe 4 or 5 years ago. They made a centralized waiting list for patient and decentralized buying of kits for the patients. So this means that we have a central in the government, it was a presidential idea. So they made a central waiting list that have all the patients in it. Before we had what we call duplication of waiting lists. So the waiting list in Aswan is the same waiting list in Cairo, the same waiting list in anywhere. But by this way, they had a computerized waiting list for all Egyptian congenital heart patients needing surgery, and they distribute them to different centers. And by this way, they know where the patients went, and they have a very tight follow-up. So the patients, when they put on the waiting list of, say, of Cairo University, centrally they come in contact with the hospital in 2 weeks, asking about what did you do. So the patient may go for surgery or for more investigation or maybe shifted to another place. So this is one thing. The other thing, which I think it made a big breakthrough, it's centralized buying of equipments. So instead, every hospital buying 100 oxygenators, so the government go and buy 5,000. And by this way, they could get the prices really low, and then they sell this to other hospitals, and by this way, they know exactly what type of oxygenators we're using, what type of valves. And as I said, instead of buying 100 valves and you go to the company and they give you a price, but when the company know that you're getting 5,000, I'm sure everybody is sure that the price will go down. And by time, in the beginning, when we started our program, this is years ago, maybe a couple of decades or more, we were very common using incoming missions. And now, by time, we're doing outbound missions. And we're doing most of the pathologists, and we're progressing slowly. Still, doing 4,500 is a good number, but we have around 18,000 to 20,000 kids that need surgery every year. And we're increasing the centers doing surgery. Thank you very much.
Well, thank you for your comments and your point about bulk purchasing. That's been said by a few people during this discussion.
Can I make a suggestion?
Yeah, please.
I think we heard so many best practices from people from different countries on this continent. I think it would be great if that's a project for the African Society to write it up in a paper as proceedings of the meeting or something like that. It would be really useful because it's amazing to hear. I mean, this what you just shared is exactly what needs to happen. Centralized, bulk purchasing, pool procuring, as well as centralized waiting lists is very important, and that's success strategy.
Yeah, Bisri, you're absolutely right, and I think we do need to publish the proceedings of this session, and we need to list all of these important points. We've had several people say, well, bulk purchasing would be a great idea. It would shift control of certain things from companies like Medtronic into the surgical leadership of the process. And that's just one of many examples. So we do need to publish this, and hopefully that will be a platform for operationalizing some of this. Go ahead.
Just one more comment. Actually, exactly this is what you're saying we're planning to do. The initiative of capital buying in Egypt is we started to, it was last June, this June, a few weeks ago. We had an expo, which is African Expo, and we're planning to do this for Africa. We're planning to get as much countries of Africa, so we'll make an international hub of the equipments, and then it will be, of course, we'll get more and more numbers and get better prices, and then we'll move it to other countries. This is already an initiative started in June. Thank you.
Yeah, you know, I've seen this work in the United States where there's a company that provides perfusion services at 500 hospitals in the United States. And the price they pay to get cannulas and oxygenators is so much better than any individual hospital. It's stunning. So that's a small example of what you're talking about. It's a great idea that we've heard from a few people. We'll have one final comment and then we'll close.
All right, thank you very much. Abubakar Umar is my name, from Sokoto, Nigeria. First of all, I think it's only appropriate for me to thank Professor Drissi Bomzibra, because he actually showed us the way in Sokoto. When I finished my training, I set up a system. I was a bit confused on where to start, how to start, and coincidentally, I met Professor Drissi, and he visited my center. He actually visited Nigeria for a different mission. I invited him to my center. He saw what we had at that time, and he pledged to support us. And with his support, we were able to start. And we are indeed very grateful, Drissi. Then secondly, the issue of missions and mentoring. I think we need to organize this, because we have had missions in other places that have been on for 15, 20 years, and yet there's no transition from the foreign teams to the local teams. A lot of problems, I understand, but as a world society, an African society, I think we can be deliberate about this. I was reading something about mentoring, and I stumbled on something they call sister renal centers, which they do in nephrology, organized by International Society for Nephrology. So what they have is like they link two centers, and there's a kind of update almost all the time, and there are targets, and there's a time duration. And with that, within a couple of years, the transition is much faster, because if we leave these missions, at times you can have a mission once in a year. And if you are doing that, one mission in a year may not give room for transition. So I think this is what I believe the world society and African society can also look into. Let's have sister cardiac centers. We have a mentoring center and a mentee center. Thank you very much.
Thank you very much for your comments. I'd like to say one quick thing, and then I'll turn it over to the president of our African Society, Frank, on my right, to close the session. And Bistra, thank you very much for a wonderful talk. We've heard many great ideas today. I think the idea of publishing this and documenting it is important. Another opportunity that we have is that a year and 2 months from now, all of us will be together in Washington, D.C. Not only all of us, but a huge majority of NGOs. So as I said yesterday at World Congress, we have this Global Health and Advocacy Village, and Dr. Overman is the mayor of the village, and he's leading this. And we're going to provide free registration for 100 advocacy groups and NGOs, 200 people. All these people will be at World Congress. Bistra and Liesl are helping us identify the list of people to invite. So this group will all be there. All these NGOs and advocacy groups, the World Society will all be there. And I think we have the opportunity at the World Congress and with some pre-work before to try to come together and operationalize some of our goals. I think Christo and the World Society can partner with many of these NGOs and use the village that's being chaired by David Overman and the new council that's being chaired by Nestor to hopefully move this initiative forward a little bit. So I think that's something to look forward to. I love the deliverables that Jim Kirkland focused on about quality initiatives under Jim St. Louis and World University under Claudia, sharing cognitive knowledge and maybe associated testing. So there's a lot of good deliverables we, I think, have from this session. And I think that we have the opportunity to do a lot of groundwork so that when we come together in 14 months in Washington, D.C., we'll have even more deliverables. This has been a great session. Thank you very much. And I'm going to turn it over to the chair of our African Society to close the session. Mr. President.
Thank you very much, Jeff. I would like to thank my co-chairs for staying behind this time to chair this program and for their contributions. I want to thank all of you also for taking the time to be here. It's been quite illuminating listening to everyone, the presenters, the contributors, the questions. There's a lot of work to be done, it's very clear. And the path seems very complicated. But I think as a start, as has been suggested, we need to put a document together, some sort of a summary at least of this session. So we have a record of what the suggestions were, what plans we need to follow. So thank you everyone for joining. I think Christo is waiting to make a comment.
Anyways, again, I'd like to join my gratitude to the one expressed by our president. So the session is over, the meeting is over. The only thing left to do is for the African Society to have its business meeting, during which the Constitution will be gone over and adopted. So I'd like to invite the members of the African Society and those in the World Society that are interested to work towards the development of congenital heart surgery and the development of the African Society to stay in the room. Let's take a 15-minute break, allow the people that want to leave, and those that are really interested, please stay. Members of the World Society that really want to get involved in helping out Africa, you could also become a member of the African Society, but you have to identify yourself and you have to stay on during this business meeting.